welcome to all of you for today's webinar on topic the fundamentals of respiratory care in COVID-19 infection. Today is the second day of the continuation of the topic, and on this behalf of the Rajiv Gandhi University of Health Sciences, I welcome our Honorable Vice Chancellor, and I welcome our Registrar, and I welcome Professor Rajesh Chennai, and I welcome all the speakers who are going to deliver the lecture today, whom Dr. Rupashri is going to introduce, and I welcome all the participants, students, and delegates for this webinar. Okay, now over to our Vice Chancellor, is it, to give his opening remarks. Vijay. Now over to Dr. Rupashri.
Thank you very much. Sir, do we have VC sir with us?
No, he's in a meeting, it seems.
Okay, sir, we'll begin the session without wasting much time. Thank you very much to all the participants and speakers. So the first talk is by Dr. Manjush Karthika. He is going to deliver a lecture on airway management in COVID-19. Over to you, sir.
Thank you, ma'am. Before I start, let me extend my sincere thanks and gratitude to Rajiv Gandhi University of Health Sciences for inviting the group of experts who are here to deliver a talk on various topics. Let me extend my sincere thanks to the Honorable Vice Chancellor, sir, and all other organizers who are here. So let me share my screen here. I guess this is visible to all of you, and I'm clearly audible to everyone. Right, madam?
Yes, sir. Yes, sir, it is audible.
All right, thank you.
Also.
Thank you. So, the next 20-minute session, I'll be discussing on various areas of airway management in COVID-19 patients. Life is not the same. There was something called as pre-COVID era. Now we are in the COVID era, and we don't know what's the future. Accordingly, we need to plan ourselves. And as medical professionals, this is one of the core area where all of them are looking into airway management. What's so different from the pre-COVID era to the COVID era? Now, the mandatory disclosure, which I need to mention here, I have no affiliational, financial, or institutional benefits or conflicts of interest to disclose. Sorry. Various equipment devices mentioned here or displayed here are solely for academic purpose. The pictures, videos that are presented here are again for academic purpose only. Some of the views expressed in this presentation are subjective to evidence-based practices and anecdotal experiences that are currently available to date. Now, when we talk about pre-COVID era, who actually have practiced in various ISUs and acute care settings, they are all very familiar about this. We have all the basic airway adjuncts. We have all advanced, supraglottic airways. We have advanced or definitive airway adjuncts like endotracheal tube. We have the airway cart or go bag. The way how we are intubating. This is the typical way like how we were doing it before. Now, coming to the current era or the COVID era, the so-called, what makes it so different? Point number one, airway access. That itself is a high-risk aerosol generating procedure. Now, we all are strictly adhering to the various PPEs available. When it comes to respiratory rounds, it is more frequent now because we actually cannot predict when these patients are symptomatically worsening or the disease progression. Now, when it comes to the management of airway or intubation or definitive airway management, we need to have a COVID airway response team. These are skilled professionals as the primary team members and with sufficient backup. Like in case, if we have a difficult airway, like an obese neck with a COVID-19 patients, we need to have a second plan B. We all are familiar about emergency intubations, crash intubations. But when it comes to COVID-19, there is nothing called as an emergency intubation. It is all planned intubation. So precaution and preparation takes time. We need to prevent such kind of crisis or what you say, a crash intubation. We need to prevent that. And we need to prepare for a planned intubation. Now, failing to prepare is preparing to fail. That's the underlying statement. Now, when it comes to this question, many times in our academic team itself, we had this question arise many times, like when to intubate a patient, right? It's $1 million question. Now, the controversy is still continuing. Now, do we have a definitive evidence says that, yes, it's time for us to intubate the patient? It's all based on the symptomatic progression of the disease. We know that there are various terminologies like phenotypes popping up when it comes to disease progression, like L-type phenotype or H phenotype, etc. Comorbid conditions of the patients adds a lot. Genetic predisposition. Now, as clinicians, we are again focusing on symptomatic presentation of the patients because all the patients are different. The only feature that actually tends us to move towards advanced airway is work of breathing, hypoxemia, fatigue. These three are the major factors that we are actually looking into. Now, do we have any objective threshold that can predict intubation? Objective threshold? Yes, something like imaging techniques, right? Now, let us take 2 examples here. One is about chest X-ray. So, a group of authors have come up with a scoring called as CORS, nothing but COVID-19 opacification rating score. So they divided, or they actually partitioned lung zones into 12, and based on their finding, they found that if this opacity is visible clearly in more than 6 lung zones, they call it as CORS scores of more than 6. And this actually meets one of the criteria to go for intubation, or this can predict intubation. So when they published their case, it was found that out of 140 cases, out of 140 subjects whom they recruited, 46 of the patients required intubation. And out of this 46 patients, 31, that is 66% of these patients had a CORS score of more than 6. So we can consider this, but again, this is again anecdotal. We need to validate data on this. Next is about, again, an imaging index, that is CT chest, CT severity score index. Okay, now this was published again by these authors, and this was actually published in a radiology journal. Out of the 902 cases they recruited, they found that 61 of the patients are meeting the criteria of severe cases, and out of these 61 cases, 34 of the patients meets the criteria to say that, oh, these people have a CT scores, grading of more than 18, which meets the criteria severity. Okay. So again, CT scan and chest X-ray can be considered here. Question again is about early versus late intubation. So the conclusion of this paper says that there is no definitive evidence to state that the timing of intubation have nothing to do with morbidity or mortality of this group of patients. Again, it is based on wait and see approach, but I'll strongly underline that it is based on subjective to clinical expertise of your medical team or your medical board members or the expert team in the group. Early experience, this term actually popped up from China, from their experiences. Now, the early intubation strategy focuses on 2 reasons. One, COVID-19 patients can deteriorate easily, and it takes time for us to prepare for this procedure, that is intubation. So that's the reason why they actually put forward the statement early experience or early intubation, actually, I'm sorry. Now, the clinical rationale for this, why are we intubating these patients? Number 1 culprit, hypoxemia. Now, this hypoxemia is actually been factored by multiple other reasons, like interpulmonary shunting. We have pulmonary vasoconstriction. We have impaired lung diffusion or impaired lung mechanics and formation of microvascular thrombi. So all these are actually factoring to hypoxemia. Rapid deterioration in these patients are not actually predictable, not always predictable, I'll say. Now, some of the other factors, as I've told before, it includes fatigueness, it includes increased work of breathing, and patients are not complying to the oxygen therapy devices or non-invasive techniques that we are using. So in that case, altered mental status, again, plays a major role here. We may need to plan intubation or airway access. Staff safety comes first. When we decide to tube the patient or to go for advanced airway management, our priority is our staff, ourselves, right? So proper donning and doffing of PPEs, yes, we all are trained in that. Airborne contact/droplet isolation, yes, and definitely we'll be looking for proper respirators to protect our people. Now, protecting the team, when I say protecting the team, it is actually again based on institutional policies and protocols. Only the primary team will go inside the room and we'll have a backup outside. Equipments are ready to go. As I have told before, we have nothing called as emergency intubations here. It is all about elective or RSI. Now, another important point need to mention here is many of the people who are working in the healthcare setting, they need to understand that when we have the patient breathing in and when the exhaled air is going out, it is actually hitting the ventilator and it is getting dispersed outside. Now, we need to keep a HEPA viral filter on the expiratory limb of the circuit to prevent the viral contamination. So circuit the ventilator, when you're circuiting the ventilator, we need to keep a HEPA viral filter to prevent further contamination. Preparing for intubation, yes, assigning of roles will be very much defined. Backup plans will be always required, and we'll try to minimize apneic time. Prior to intubation, we need to go for apnea, right, to paralyze the patient. So this time need to be minimized. Now, the setting of the room, how it looks like. We always prefer to go for a negative pressure room so that to prevent further dispersion or contamination of the surroundings. We will have the airway operator or the primary intubating person on the head end of the patient. We'll have a team leader or a secondary person who is expert in airway access near to him. We'll have an airway assistant, and we'll have the runner or a nurse for administering medicines as well. Okay, and we'll have a team outside waiting for any further comments. And how these people are going to communicate to each other, since the door will be closed. We'll have a speakerphone or something like electronic communication device like Vocera to communicate to them. Now the trolley, the typical trolley will be used, plus along with that, the intubation trolley will always have a video laryngoscope. Video laryngoscope is a new concept. It's not a new concept actually, but in the COVID era, it's like a regularized concept now. Prior to the COVID era, we didn't use video laryngoscopes much, but now it is taking the first line priority. Don't forget the basics. When it comes to airway management, don't forget the basics ever. So a patent working IV line or IV cannula is needed. Not one actually, we need 2 or 3 IV cannulas. Sedatives, relaxants, muscle relaxants, we need vasopressors, or some places, or as per the guidelines, we are giving prophylactic vasopressors as well. Fluids need to be on stock. We need to have a working suction apparatus. We need to have multi-para monitoring. We need to have a BP cuff that is cycling every 3 to 4 minutes, or we need to have an arterial cannula. Pulse oximetry for sure, and the sound should be clearly audible. The high priority alarm need to be set for pulse oximetry. ETCO2 is required, and cardiac arrest trolley will be kept outside. In case if there is a crash or if there is a crisis, we need to pull the cardiac arrest trolley inside the room. Preoxidation. Again, a topic of controversy. There are some places or some articles that are saying that, yes, you can give, normally when we induce a patient, we need to give some breaths, right? So this is not recommended here in COVID-19 patients, considering the fact that these are aerosol generating procedures or it can disperse aerosols. One of the study have proved that hypoxemia, like we know that during induction, the patient can go for hypoxemic insult, right? One of the paper has clearly stated that more than 73% of the patients were having intra-procedural or during the procedure, they had this crisis of hypoxemia. Speed matters. Trained hands are required here. Rapid sequence induction or rapid sequence intubation is actually recommended by most of the societies and not the emergency intubations. We need to prevent emergency intubations. Like 3 to 5 minutes of apneic pre-oxygenation is supportive, and manual backmask ventilation is tried, like we need to avoid that. If at all, if it is used, that need to be, again, subjective to the clinical expertise. Airway access techniques. First line goes to, I'm sorry, the first line goes to video laryngoscopy, and it is actually taking the term gold standard techniques here. Now, the second one, I'm using the term here, second generation supraglottic airway device. If we are not able to access, the cord by video laryngoscopy, we can actually plan for a supraglottic airway device that is a second generation. Usually, PLMA or iGel can be used. Even if we are failing with that, the next option is go for surgical airway. So this is nothing but a scalpel bougie crack technique where we'll be going for a nick in the cricothyroid membrane and inserting a cricothyrotomy tube. Conventional intubation is not recommended, but however, it is in practice in some places with barrier devices. Now, something about endoscope guided. We know that we have something called as fiber optic intubation techniques, right? Now, this is not actually recommended, but still in practice, but based on their report and anecdotal experiences. We do not have definitive randomized controls to state that we have to go for 1, 2, 3, 4. These all are based on consensus guidelines. Now, most of you might have seen this, the barrier devices, right? The aerosol box, or you'll have the aerosol sheets or tented sheets, etc., etc. In anesthesiology journal, it is actually been published recently that none of these techniques or barrier devices are found to have no benefit. Rather, higher chance of aerosol exposure to the intubator, the person who is intubating, the chance of aerosol dispersion is more, plus the delay in procedure. So still, it's all based on this meta-analysis and whatever report they have analyzed. Coming to the gold standard technique, we have video laryngoscopes. As I've mentioned, the mandatory disclosures, I have nothing to do with these kind of brands. These all are meant for academic purpose. So we have CMAC, blade scope, Medtronic, different types of blades are available, scopes are available. Most of you might have seen these things in your practices. Now, I'll just show you one of the video laryngoscopy demonstration, like the practice, which is actually published in Lancet Respiratory Medicine Journal. I'll just play that for you people. Okay, can you click into it? Oh, where's the cursor? So this is the typical face-to-face intubation, the conventional intubation. Now here you can see that the intubator is using a video laryngoscope. So that makes it actually very simple. The face-to-face contact, I mean, the patient face to the intubator face contact is very minimal, and the chance of aerosol dispersion is much less compared to the close or the proximal contact. Yeah. Now, how are we going to confirm the technique? Yes, direct visualization. If you are using a video laryngoscopy, you are directly going to visualize the code and we are confirming it. End-tidal carbon dioxide can be used. Bilateral chest rise, you're not going near to the patient. Again, there is something called as airway or lung ultrasound can be used, focus, and 5-point auscultation, like typical way of the confirmatory techniques. Most important to remember, immediately as you intubate the patient, inflate the cuff and clamp the tube. That plays an important role. In case if the patient is coughing or if there is any aerosol that is getting dispersed, we do not want it to be spread out. So we need to clamp the endotracheal tube. So I've mentioned 2 points here. Before you connecting to the patient and before you disconnect the patient from the ventilator for any reason, we need to clamp the tube, the endotracheal tube with the artery forceps. Okay. To summarize the whole process, the preparation is based on donning, lean team or minimal people, the trained people inside. Backup providers will be there for you people, and call for help if there is any difficult airway which is actually anticipated. Closed loop communication is required within the team, and intubation huddle plays an important role here. We need to make a clear plan of what we are going to do with this procedure, during this procedure. During the procedure, like intubation will be performed by an experienced provider, pre-oxygenation for like 3 to 5 minutes, and definitely we'll have a viral filter on the back mask that you have seen before. RSA technique is actually recommended. Young children may not tolerate apnea, considering their respiratory system is not fully developed. So in that case, we may require to give back mask ventilation for these small kids. Video laryngoscopy is strongly recommended. If performing direct laryngoscopy, maximize the patient and the intubator face-to-face difference. I mean the distance. Again, to continue with the same, consider using the second generation supraglottic airway device. I have mentioned that already. iGel is preferable. And mask ventilation only in case of crisis where the patient is deteriorating. Immediately inflate the endotracheal. Once you intubate the patient, inflate the cuff and clamp the tube before ventilating the patient. Okay. Attach the circuit with HEPA viral filter. We have mentioned that very clearly. Confirmation again we have told. Okay. So if you look into one of the criteria that they have mentioned, we can see that the airway plans. Plan A is always video laryngoscopy with bougie and Stilett. Second is supraglottic airway. Third, we can plan about back mask with two people holding the mask on the face, and the plan D is going for a surgical access. All right. Now, the pause procedure, limit the disconnection from the ventilator circuit, unnecessarily do not break the circuit, discard all the airway equipments to a pre-designated plastic bag, doff PPE properly. We don't need to contaminate the surroundings again. All right, take-home messages, know your system, that's more important. We are talking something here, not necessary that your hospitals are following the same thing, right? It's all about your system. Follow the policies and protocols in your system. Remember the sentence, primum non nocere. We should not harm anyone. And in case, if you are confused about something, always call for help. Okay, thank you.
Thank you very much, sir. So
I tried to make it a bit fast because I need to stick on to the timing. So
yes,
we already started a bit late, so I was a bit rushing.
Yes, all 6 speakers will have approximately 18 to 20 minutes to complete that presentation to be on.
Yep.
And thank you so much for your detailed presentation. So this is for the information of all the participants. We will be starting our second presentation. We have now with us Ms. Rujuta Bagade. She has done her bachelor's in respiratory therapy from Symbiosis Institute of Health Sciences and master's from Mahe, Manipal. Presently, she is working at SL Raheja Hospital, Mumbai. And now she is going to give a presentation on mechanical ventilation, initiation and management. Over to you, madam.
Am I audible?
Yes, madam.
Yes.
Okay. Thank you so much for that kind introduction, ma'am. So firstly, good afternoon, everybody. At the outset, first, I'd like to thank the Indian Association of Respiratory Care and Rajiv Gandhi Institute of Health Sciences for conducting a session like this, which is of importance considering the scenario outside and the number of the urgent surge in COVID-19 cases. So what we need to understand right now is not all of the patients who are detected as COVID positive land up in the ICU or need mechanical ventilation. A very few percentage of these people require mechanical ventilation, and it is so we need to aim our strategies, to prevent unnecessary complications in this ventilation. So now the major question that most of us have here is when is the right time to intubate these patients, and because of the associated risk factors associated with mechanical ventilation and mainly the aerosol generation to the healthcare providers. So before I start, I have a few disclosures to do. I have no affiliation, financial or institutional benefits or conflicts of interest to disclose. Some of the views expressed in this presentation are subjective to evidence-based practices that are currently available in the literature. Also, I would like to state that one size doesn't fit all. So while many of you might be carefully looking at my presentation today to understand about the mechanical ventilation in these group of patients, one thing that you must all remember is that you will need to tailor the management according to each individual patient. And what I have tried to lay down in my presentation may work for most of the patients. So most of these things that I have laid down in my presentation are based on the evidences, the logic, and some scientific intuition. So even as I talk to you today, we are coming up with a lot of studies that are taking place, numerous trials are taking place, and we all are learning. The entire world is running right now. So I understand that people from different backgrounds are, attending the session today. So I thought, so as to keep all of us on the same page, I'll quickly sail you through what the classical definition, the Berlin definition of ARDS, which suggests that ARDS is said to happen when a patient has an oxygenation problem, that is his partial pressure of oxygen by your FiO2 of less than 300 in a ventilator patient with a PEEP of more than 5 centimeters of water. The respiratory distress occurs within 1 week of a known clinical insult with new or worsening respiratory distress. And the chest imaging shows bilateral opacities, which is not completely explained by pleural effusions or collapses or nodules. And by oxygenation issues, I mean it can be categorized into mild, moderate, and severe ARDS based on the P/F ratios, wherein the severe group of patients fall when they have a P/F ratios of less than 100. So another way I would like to mention here is that most of the COVID patients, which I have seen in my practice, have even had P/F ratios of less than even 80 for that matter. So as Bill earlier, I used to feel that COVID ARDS and the start is quite or more or less similar to our traditional ARDS, but now being 1 year into the COVID pandemic, we have realized that it differs from the traditional ARDS in terms of the onset of symptoms. So a traditional ARDS is said to happen when with the insult after within 1 week of the insult, the symptoms start to begin. But with COVID ARDS, the symptoms are beginning between after almost 2.5 days after the onset of dyspnea. So Gattinoni has, described the lung phenotypes, which I'll quickly take you through. That the typical COVID ARDS lungs typically show two types of phenotypes. One is the L type, wherein the lungs are very, very compliant. They can expand very easily. The lung water is very, very minimal, and as also the alveoli are well aerated. Whereas the H type shows is the type wherein it shows very low compliance. The lungs are very stiff. They have extremely a lot of water within their lungs, and they are much better recruitable. So over a year of practice right now managing COVID patients, I thought I would take you through today. While I take you through the ventilator management, I thought I'll take you through some of the cases that I have come across. So quickly taking you through a case of a 33-year-old male who was a previous healthy man, COVID-19 positive. He presented to the emergency room with 2 days of worsening dyspnea. He had fever, cough, and fatigue during the week before the presentation. He appears to be acutely ill. His body temperature around 39.5 degrees Celsius, that is around 103 degrees Fahrenheit. He was tachypneic as well as tachycardic. His heart rate was around 110 beats per minute and respiratory rate around 54 breaths per minute, BP around 130/60 mmHg. His oxygen saturation on ambient air was around 85%. So we put him on an NRBM, and his ABG on an MRBM showed a pH of around 7.38, a PCO2 of around 42.4, PO2 of around 73.20, which is extremely low, that with a P/F of almost less than 80, and bicarbonates of around 24.30. So we weren't able to take a CT scan at that particular time, considering his condition, because he was in severe respiratory distress, as you can see. So we did manage to get a chest radiograph, which showed patchy bilateral opacities in the lung parenchyma. You can see his X-ray here. So how would you try and manage a case like this if it comes to you? So we first did try and evaluate and determine if the patient was in respiratory distress. And by respiratory distress, I mean the patient having tachypnea, the patient having nasal flaring, and the patient using his extracellular muscles for respiration, which is his sternocleidomastoid muscles or abdominal muscles. So we immediately started him on NIV, and 2 hours after starting him on NIV, we had started him on mild sedation such as dexmedetomidine or fentanyl infusions. And despite all this, the patient's respiratory risk continued to be severe. His respiratory rate going up to now even 60 breaths per minute. So he was not really cooperating well with the therapy. And so here comes our important decision as to when is the right time to intubate. So, over the past 1 year, we all want to that we've been in the pandemic. We all know that we want to be right bang on time, that you want to intubate the patients. You don't want to be late. And we, sort of burnt our fingers with quite a few number of patients who, when these patients looked very comfortable with respiratory rates ranging between 20 to 25 breaths per minute, and with raising FiO2 requirements, they looked very, very comfortable. And with this hypoxemia concept settling in, you really used to feel very, very sorry to intubate these patients. How could we just the when is the right criteria to intubate. Whereas I feel right now it is based on the clinical gestalt, which is supplemental with all the vitals like your respiratory rate, the saturation, the efforts of the patient, and emerging. It should not be solely based on your respiratory rate, because it is some amount of retacapnia is going to occur with lung inflation. So probably the best metric will be the respiratory effort and thus fatigue. Sorry.
No, madam, please carry on.
Yeah, okay. Sorry. The altered mental status, which and agitation, which can prevent the application of NIV, would be another indication to intubate these patients. Moving ahead, that now you have decided you have to intubate these patients considering all the things that have been mentioned in the earlier presentation. So now you put the patient on a mechanical ventilator. So what is basically a mechanical ventilation is the ventilation of the lungs by artificial means, usually by a ventilator, and which delivers gases to the lungs with either with your positive pressure. And the main purpose is to maintain or improve your ventilation and tissue oxygenation, and to decrease the work of breathing and improve the patient's comfort. So once you've decided and once you've intubated the patient, you put the patient on a mechanical ventilator. So you have the basic two standard conventional modes which you put on. Either you go with the volume controlled ventilation or you go with the pressure controlled ventilation. Volume control ventilation, you have your FiO2s, you set your tidal volumes, your positive and respiratory pressures, your inspiratory ISU ratios, and your respiratory rate. And in your pressure control, you set your pressure controls, which is the only difference between your volume and your pressure control instead of the tidal volumes. So commonly at our setup, we are using the volume control mode of ventilation, and we use PCV only if the patient is having uncontrolled peak pressures shooting high. So once you put the patient on the volume control mode, we start off first with the FiO2, which is you usually start with 100% FiO2, and then titrate in accordance with the saturations. And as a lot of studies have mentioned, you go with the low tidal volume, that is your lung protective strategies, wherein you initiate the patient with around 4 to 8 ml per kg of predicted volume weight. So there have been studies which have showed mortality benefits with ventilation with lower tidal volumes as compared to your traditional higher tidal volumes. Then you set your respiratory rate at about 20 to 30 breaths per minute. Then you have your main setting, which is your PEEP. So what we have been doing is, as soon as you intubate your patients and you put the patient on a mechanical ventilator, we basically start, check the compliance of the patient then and there as the patient is sedated, because when you're inducing the patient to intubate, the patient will be sedated. So that's the best time to, check the recruitability of the lungs by checking the compliance. So high PEEP can reduce the required amount of inspired oxygen, FiO2, by improving your gas exchange and lung compliance, whereas even setting too high PEEP can cause your lung over-distension and hemodynamic instability. So we should be aiming at the lung protective strategies to improve and to minimize your associated lung injury and thereby improve the survival. Remember to just give enough oxygen to maintain adequate tissue perfusion and allow some amount of permissive hypercapnia. So when you're putting these patients on mechanical ventilators, two important things that you should keep in mind and have a constant monitoring is your plateau pressures, basically which refers to the pressures within the alveoli. Okay, and the second, and try to limit it less than 30 centimeters of water. And the second thing is your driving pressures, which is your plateau pressures minus your PEEP. We should be limiting it below 15 centimeters of water. So in spite of doing all these things, you see that the patient is still not picking up his saturation, and he still is continued to have a very low, despite giving him 100% FiO2. So the next thing that you should come to in your mind is the DOPE with any patient who has been on mechanical ventilator. DOPE is a mnemonic for dislodgement of ET tube. So wherein you check whether the ET tube is in place, it can help it with your EtCO2, or you check if there are any disconnections in the circuit. Then the second thing is obstruction, which I feel is very common with this COVID patients, which in my practice is because these patients have been on antithrombolytics, they tend to bleed from the ET tubes, and which tends to clot and block So very common, and you're proning this patient. So, mobilization of secretions and all. So it is common to have obstruction in the ET tubes. The second thing is pneumothorax. You need to check on if the patient is having a spontaneous pneumothorax. You can aid it with your chest x-rays. And the last thing is your equipment failure. So disconnect the patient from the ventilator, take him on a back mask ventilation, and check if there is any failure in the equipment. You've done all this, and still you see that the patient doesn't improve. That shows that we have some underlying lung pathology. So that is when we go to our the most commonly for talk of this is your recruitment manuals in COVID-19. So few questions to answer. Is your recruitment manual for anybody with patients, with anyone who has a low P/F ratio? So no, as I mentioned earlier, we have two phenotypes of the COVID-19 lung. So, some patients are responders, and while some are non-responders. So it is important to identify the responders and non-responders to the recruitment manuals. The second is what is the goal of it? It is to increase your transpulmonary pressure, which is your alveolar pressure minus your pleural pressure. And this is that is the actual pressure that is just tending to open the collapsed alveoli. So this basically leads to improved compliance of the lung, improved oxygenation, and this may occur usually in a matter of time, or gradually over a period of some hours. So you need to be very careful, and when you need to evaluate these patients, and set in the right time when you start off with the recruitment manuals when there is a refractory hypoxemia. So once you're recruiting these patients, some common questions that might come to us is when and how do you perform these recruitment manuals? How did the individual patient respond to recruitment manuals? As I mentioned earlier, not all patients are same, and some patients might respond to recruitment, some might not. So it is important to tailor our management according to each individual patient. How we need to keep into consideration how different lung regions are responding to recruitment manuals, and what peak should be set after the recruitment manual to minimize the re-recruitment and over distension, which is most commonly thought about when recruiting these patients. So we have two methods. I'll quickly take you through that. So that is one is your sustained inflation recruitment manual, wherein the patient has to be sedated and you shouldn't be coughing on a ventilator. Put the patient on a CPAP mode, and keep the pressure support as 0, and keep the pressure P, that is your positive and expiratory pressure, at 30 centimeters of water for about 30 seconds. So with this method of recruitment manual, basically the effects are quite transient, because moreover you're going back to the same settings as earlier after your recruitment manual is done. So you are going back to the square one, and you might again feel that the patient has re-recruited. So you're back to the square. So the another method is your staircase recruitment manual, which is most commonly used, and even we are using it in our setup. So you put a patient on a pressure control mode, wherein you are keeping a control over your driving pressures. As I said, your driving pressure is your plateau pressures minus your PEEP. So what you do is you start the patient with 6 to 8 centimeters of water, and gradually increase the PEEP. Then that is your staircase manual, with 2 centimeters of water, and that you do to maintain your driving pressures at 15 centimeters of water. So you slowly reach your PEEP of 30, and then you start coming down in the reverse order. So say you've gone from 8 to 30, then you start going from 30, 28, 26, and so on, and reach back. So when you're giving this recruitment manual, you need to observe two things. One is your compliance. So for example, you've started with 8 of PEEP and you go to 30, and somewhere when you're going around 14 or 16 centimeters of water, you will gradually first see an increase in compliance, and then you might see the compliance is stagnant. It stays. Suppose you've started with 18 and you've reached around 22, 24, and then you see that the compliance stays there. It doesn't continue to increase, or it's rather sometimes might start falling down. So that is one thing you need to see. And second is your pulse oximeter readings. That is your saturation, where the point at which the point where you start your PEEP, the point at which your saturation improves or starts dropping. So this will give you your something known as your optimal PEEP, which is very important. And once you get your optimum PEEP, you can straight away, once you have finished with your recruitment manual, stop at that PEEP and leave the patient on that PEEP. as I mentioned earlier, some few questions that we might have as to what is which patients, and to see how lung regions are, responding to your recruitment manuals. So we have been fortunate enough to have electrical impedance and chromography in our setup, which is an ideal tool to assess the lung recruitability. It helps identify your responders for your recruitment and your not responders. So it is a non-invasive, radiation-free clinical imaging tool in real time and at the bedside, which is tells us the distribution of ventilation. So it can help you, in deciding whether prone position can be used and when it is the right time that you should be proning the patient. So in severe COVID-19 ARDS patients, it is used to optimize mechanical ventilation settings, providing useful information when titrating your personalized fee. It can be helpful in evaluating the possibility of lung recruitment manuals, estimating the recruitable alveolar collapse. And it also can be used to determine, the postural dependent changes. So you can basically, in this electrical impedance tomography, you can see the ventilation, the regional ventilation, and you can see the areas which have not been ventilated and try and monitor and, alter your therapies and give proper positioning to, give, in the less aerated areas. So studies have shown that it might be useful in detecting some early signs of pneumothorax, and also it can be used in seeing pleural effusions in the ICU patients. So this is a picture of how the ventilation, the regions of interest and how it is distributed. So you have your quadrants wherein you have your right and left upper quadrants and right and left lower quadrants. And you have it is distributed into the percentages. And also so there are the different modes views in which you can see it according to the layers and in the quadrants. So this will basically help you know which quadrant is not getting ventilated, and then adjust your therapies accordingly. So a small example of our patient, how does the EIT look pre and post recruitment? It is very evident. See, in the pre-recruitment phase, you can see the right upper quadrant not getting well ventilated. But 10 minutes and after almost 4 hours into the recruitment, you can see well ventilation and proper distribution as in the layers. It also has a diagnostic mode wherein you can actually, when you're giving, so this is a staircase recruitment manual that was given to the patient, starting from 4 centimeters of water PEEP to around 14 centimeters of water. And you can see the drastic improvement, and you can see the response to the recruitment manual where, the patient's ventilation has improved. So now, as you can see in the case that I mentioned earlier, we had tried and, did a recruitment manual in this patient. And this is the pre-recruitment and the post-recruitment photo that you can see, and you can see improvement in the ventilation of the patients post-recruitment. So what we had tried to do was, once we are giving recruitment and get checking, and this is aiding us in deciding the therapy. So we are giving positionings, so right lateral or left lateral positionings accordingly, and you can monitoring the patients. So you've done all these things, you've recruited, you've used your EIT if available at your setup, and recruited and managed these patients, but you still find that the patient is not improving. The saturations are just at borderline, and he's still not able to, as I said, the hypoxemia is still not settling down. His BBF ratios are still down. So where are we? Are we there yet? Are we reached our targets? So this is when our prone positioning comes into place, and we had a very wonderful session by Pramila ma'am yesterday, where ma'am has explained in depth about prone positioning and the goals and what is the benefits and how should you prone a patient. I'm not quickly going into the details of it. So then we'll go on to move on to the same case, and we check what has happened with him. So he continued to be on the ventilator for almost 15 days. He underwent almost 3 to 4 sessions of proning, had increased inflammatory markers. As we all know that these patients are usually on antithrombolytics. So he had a one good fine day when I was supining this patient post a proning session. I noticed that this patient had a subconjunctival hemorrhage. He had nasal bleeds. So we were really in a tough spot, and we thought that we would usually lose this patient. But when day 10 or day 12, dramatically we saw some signs of improvement after almost 4 sessions of proning, and we were gradually able to taper his FiO2 requirements to around 40%. So day 14, we gave him his first SBT trial, which he passed. And then we put him on intermittent volume control and pressure support ventilation as a weaning, when we started with our weaning procedures. So this is something that you can, once you're able to get off the patient's FiO2 requirements, you can slowly start them on a controlled and a pressure support ventilation. And then one very important point which I would like to mention is about mobilization and early mobilization in these patients as and when is possible. So because these patients usually who are on long-term ventilator go into something called as critical illness, myopathy and polyneuropathy. So it is important to mobilize these patients as and when possible, and also increase their self-confidence. When believe me, it just helps them dramatically. And then day 21, we were able to extubate him happily and put him on an HFNC, which we have been using quite often in our patients. And I'll show you as and when we were able to get his CT scan done. So I'll show you his CT scan. So this was one CT scan, which is, which was before his extubation. So you can see, changes and improvements in his CT post his extubation. So I'll take you to another case. This is of a 67-year-old male who was has case of diabetic hypertensive and CKD. He was non-oligarchic. He was admitted to the wards with symptoms of cough, cold, mild dyspnea on exertion, and his vitals were around 89 heart rate, BP over 150 over 80 mmHg, respiratory rate around 20 per minute, and saturation was 92% on Romel. And he was in the ward, so he was, put on nasal prongs and gradually escalated his O2 therapy, and he was put on an NRBM, and then he had increased inflammatory markers, his CRP, D-dimers, ferritins skying high up. And then that's when they decided and they shifted him to the ICU. We received him, we put him on an HFNC, and then we gradually had to put him on a helmet because of his increasing FiO2 requirements. But dramatically, this patient, as I mentioned, the hypoxemia, wherein patients look very comfortable. He always looked comfortable. His respiratory rate was always between 20-25 breaths per minute, and he never had that as such that tachypnea or that that work of breathing, increased work of breathing. So and his P/F ratio was less than 80. So despite being hypoxemic, he never showed that. So it was a tough call, as I already said. It's a tough call where you want to intubate the patients, but we went ahead, we intubated, and that's then we initiated him on an ACVAC mode. I had put him on an FiO2 of 100%, the tidal volumes of around 400 ml, respiratory rate of around 22 per minute, IS/E ratios of around 1:2, and a PEEP of 10 centimeters of water. That is the usual PEEP that we start patients with. We tried and started at the bedside, as I mentioned earlier. We tried and did recruitment him. But he had no effect with recruitment or increase in PEEP. His compliance would just drop, and he had a first compliance of 18. So his compliant first drop, we proned him immediately. He underwent 2 to 3 sessions of proning. But despite all this, we could see that he had no improvement as such. His FiO2 requirements did reduce, but then the moment we used to supine him, we used to see that his FiO2 requirements always used to go higher. So that is when we put him on an APRV mode, which is an advanced mode, which basically applies your CPAP, that is your P high, for a prolonged time, that is your T high, to maintain your adequate lung volume, and alveolar recruitment with the time cycle release phase to a lower set of pressures, that is your P low, for a short period of time, that is your T low. So, or that is your release time, or that you can call as your dumping breath, where most of the ventilation and your carbon dioxide removal occurs. So some of the advantages of over conventional ventilation include your alveolar recruitment, improved oxygenation, preservation of spontaneous breathing, improved hemodynamics, potential lung protective effects. So the moment we put him on an APRV mode, we noticed some signs. We left him on an APRV mode for say 1-2 days, and then we slowly noticed some signs of improvement. And then we knew that he was going to require long-term ventilation support. So we had to tracheostomize him on day 10 to 12 and had to reprone him with APRV. And then we came into our impedance tomography, where we guided and we did recruitment. We did positioning with him, right, lateral, left, lateral positionings every 2 hours, seeing his areas which have not been ventilated. And slowly we were able to wean him off APRV and put him on a CPAP mode. We started giving him intermittent trials of TPs, and then slowly it was sent on TT with O2 therapy. And that is one very one of our success stories where we could, go ahead in 2 months post-COVID, he had come to us for decannulation. So we have seen, when all these therapies have failed to work, they have something as the adjunct therapies, which can be used in this group of patients. One is our inhaled nitric oxide therapy, that is, which is a naturally occurring vasodilator, which is administered directly into the lungs, mixed with the ventilation gases, and is absorbed into the pulmonary circulation through your aerated alveoli. So basically, our inhaled nitric oxide acts as a vasodilator by increasing the blood flow through the aerated areas of the lungs. And then comes your ECMO, that is extracorporeal corporeal membrane oxygenation, which is a rescue therapy for patients with refractory hypoxemia, wherein the external machine replaces the functions of the heart and the lungs. So basically, the ECMO machine pumps blood from the patient's body to an artificial lung, that is an oxygenator that adds oxygen and removes the carbon dioxide, and thereby replaces the functions of your lungs. So, and also you have something called as the VA and the VV ECMO. I'm not going into the details of it due to the limited scope or limited timings here. So we'll go on to the weaning and the extubation. So what we have noticed is with COVID-19, which it leads to an atypical form of ARDS, wherein we have heterogeneous lung pathologies with relatively well-preserved lung compliance, despite being having severe hypoxemia. So extubation as such is also again a high-risk procedure as intubation in patients with COVID-19 because of the direct contact with the patients and the exposure to the aerosol droplets and aerosols. Because you, as an intubation you would be sedating and probably paralyzing the patient. So you have reduced the airway aerosol production, but that is not as in the case with extubation. So it has. You need to be very critical and to ensure that the decision to extubate is very appropriate because firstly, you want to not harm the patient due to early extubation, and also you need to prevent the hazards which might occur with re-intubating these patients because that is going to again increase your exposure to the aerosols. So when weaning, I'll just mention quickly here that when weaning patients of mechanical ventilation, first try and wean them off FiO2 first and then go to PEEP because this FiO2 first is going to weaning off long-term, keeping these patients on long-term oxygen is firstly going to cause them oxygen toxicity and the other associated complications. So first try and get them off FiO2, let the PEEP be there at around 10, 12, whatever is your optimum PEEP, and then slowly try and getting off that PEEP. Also important to give daily spontaneous breathing trials with the pressure support for 30 minutes or your TPs for 2 hours can be performed to determine whether these patients are ready for discontinuation of mechanical ventilation or not. And then progressively reducing this pressure support when you're giving these daily spontaneous breathing and sedation vacation trials is a good method when you are considering the weaning in this COVID-19 patients. Moving on to the criteria which is being used in weaning these mechanical ventilated patients. First is your best clinical criteria before starting an SBT, bedside x-rays which suggest lung disease, remission or absorption of the underlying lung pathology, adequate oxygenation with the P/F ratios equal to at least 200 and with less P/F requirements of around 5 to 8 centimeters of water, and your reduced FiO2 requirements of at least 40 to 50%. Stable cardiovascular systems, the patient should be having adequate cough, adequate alveolar ventilation with a pH of more than 7.3, and he should not be hypercapnic, should not be febrile, shouldn't be having fevers, should be having a GCS with no continuous sedation zone, and should be having metabolically stable. So I would like to mention here a small ISU Liberation Bundle, which is published by the Society of Critical Care Medicine, wherein you have the approach to any patient of Liberation, ISU Liberation Bundle, wherein the approach to any patient who is on a mechanical ventilator should be such that the patient you're able to give him daily sedation vacation trials. Okay, you're able to meet the criteria for extubation, you're able to prevent and adequately give analgesia to the patients so that these sedation, adequate sedation, and delirium, which is very important because many of these patients might go into ICU delirium. Early mobility, as I mentioned earlier, mobilizing these patients as SAP is very important. And then is your psychological support for the family as well as for the patients. So some take-home messages. First is do not delay intubation. If you see the patient is struggling, gasping, his work of breathing is going high, and even in patients with the FiO2 requirements are going high and the work of breathing is going low, you try and even if the work of breathing is not there, you try intubate the patients. Effective use of ventilator strategies in patients with good and with also with poor compliance. Use of low tidal volumes to reduce the volume trauma, and effective use of PEEP. Optimal PEEP should be kept into consideration, to reduce the lung injury. Use of electrical impedance tomography in lung recruitment, proning, and the ISU Liberation bundle should be kept in mind. Taken a lot of your time. Sorry, I exceeded my time limit, because this is a very vast topic and it was difficult to constrain. But I've tried my best and taken all the possible things that I should be included and felt are important. So thank you so very much for your patient listening. Take care, stay safe. Thank you.
Thank you. Thank you very much, madam. And we have a lot of queries in the chat box requesting for the slides and the link. It is to the information of all the participants that the entire session, yesterday's and today's, will be available in RGHS website for any future reference. So we now move on to our next presentation. We have Ms. Tisha Anskaria as our third speaker. She has graduated from Mahe, Manipal. She is a respiratory therapist specialized in neonatal and pediatric respiratory care. Currently, she is working as a director of respiratory care at Kanad Hospital, Al Ain, UAE. She is going to present a talk on respiratory care in pediatric COVID-19 patients. Over to you, madam. Please unmute yourself, madam.
Sorry. Thank you so much for the kind introduction. I will quickly go to my presentation. Just a minute.
And speakers, we have questions in our chat box as well as in Q&A. So you can just see, and whichever is to your subject specialty, please give answers. Thank you. Please go ahead, madam.
Yeah, okay. So my topic is on respiratory care in pediatrics who are suffering from COVID-19. Well, I thank the IRC and the academic wing of IRC and the Rajiv Gandhi University for teaming up for such a wonderful sessions from past 2 days. So disclosure statement, I have no affiliations or financial benefits from contributors to disclose. The equipments, the pictures and the devices mentioned are of solely of not any personal interest. And the views that are expressed in this presentation are subjective to evidence-based and anecdotal experiences that are currently available in the literature. Okay, moving on to COVID-19 in pediatrics. Yes, it's a mild illness trajectory compared to what the world is globally suffering, as we are, just witnessing the trauma that is happening from the last year. In children, it is mostly asymptomatic. That is 90% of it presents asymptomatic. This is from a retrospective Chinese data that was published last year. According to CDC in 2021 February data, age 0 to 4 is 1.9% are affected, and the other age group it is 9.4%. So it's a very less percentage that is affected compared to the globally affected or the adults that are really being affected by this virus. A small proportion of them is present with something called as MIS-C, that is multi-system inflammatory syndrome in children. As per the data of CDC again, which was summarized in 2020 August, lower hospitalization rates compared with adults, that is 8 versus 165 per 100,000. It's very less. And 1 in 3 hospitalized require ICU, which is similar to the adult ratio when we see those requiring the ICU admissions. Mortality rate in pediatrics is less than 1% of all the, if you see the globally, the deaths and the age groups that you have. The risk factors for severe illness in children are clarified and not clarified, and we are waiting for answers from the ongoing researchers, and we are yet to receive answers on this. So whatever I'm going to be presenting in this presentation about COVID-19 in pediatrics is going to be basically an extrapolated data from what we have with the data that is present with the adults, and with whatever consensus that different hospitals and institutes are following. So how do they present? They present with a short history of prodrome with myalgias, malaise, cough, and low-grade fever. Second week of illness will present with dyspnea, pneumonia, and pneumonitis. A very few percentage of children will have hypoxemia, that is oxygen less than 92%. That is like 1 to 2.3%. How do we diagnose? Yes, we need the RT-PCR. Even if we have radiological changes, we still go by the RT-PCR confirmation. It is not possible, very difficult to differentiate the COVID-19 from the other viral diseases. And we can use the lung ultrasound only to monitor treatment response, not to diagnose. Severity classification, again, the patients, they said that they shed RNA every 1 to 4 weeks after symptom resolution. The presence of RNA, is it equal to the presence of infectious virus? Well, it's unknown. So the current guidelines say you have to have 2 consecutive negative RNA tests collected 24 hours apart, but in our resource limited settings, and everywhere, everything is getting very limited. And even in the most resourceful places, we have to be very constrained. So this is not very logistically possible. So what is the solution for it? Keeping them in isolation for longer duration is the key that we follow. Why is it less severe in children? This is one question that is over and over asked. At the same time, we are happy about it. Very, very happy that it is keeping our children away from the virus and from the tortures that is being that this virus causes. One is because it has a lower exposure. The children are low exposed, well crafted at home. We keep them safe at home, and that's possibly one of the hypotheses. The next is lower expression of the ACE2 inhibitor receptors in children. So they're not, the response to the virus is different. The immune response is responding differently to the COVID virus. And it is also seen that the lymphopenia is actually 3.5% in children compared to the adults. There are frequent other viral infections in children, and vaccination could possibly be enhancing the immunity in different ways, which could be the reason why they are responding less severe to this virus. Comorbidities are less or kind of absent in children crowd compared to the adults. So the complications presented are less severe. So you will see that that we are seeing less severe or less complicated cases of COVID-19 in children, apart when they go into something called as NISC or some inflammatory responses. Transmission from children to adults and caregivers, this is something that we all have to be very cautious of because they can be silent carriers. Okay, so predominantly transmitted from respiratory droplets. School-related transmission report is very limited. That it is a very limited number of transmissions have been reported because of school. 89% of cases have had viral shedding through the gastrointestinal tract for 4 weeks after the swab becoming negative. Now, this is of a concern to us. Should we be really bothered about this? Again, there's no definitive data on this. What we can do is standard prevention measures should be diligently followed. Now, what is this multi-system inflammatory syndrome? It's presence of fever for more than 24 hours, elevated respiratory inflammatory markers, multi-organ dysfunction, that is more than 2 systems are involved, more than or equal to, no other alternative diagnosis that has been found, and positive viral or serological testing of the COVID or close contact with the person with a confirmed COVID test within 4 weeks of symptoms onset. Now, coming to the respiratory care management, where I will be briefing you on all the modalities that what we can do with this age group. I would also like to mention that I'll be touching on all the presentations that we had in these last from yesterday and even today. And I'll be just mentioning what is the highlight that we can actually concentrate for our pediatric age group. So let me start by saying that the data on requirement for the respiratory support and mechanical ventilation is scarce in the pediatric population. There is currently no RCT that has been published or there for us to refer on. Data and guidelines are extrapolated from the adult data that we have. Now, who needs help when they have COVID is only, respiratory help is those who are in hypoxic respiratory failure. There is a risk to the healthcare workers. So as Dr. Manjush was mentioning, first, we have to be also concerned about the healthcare workers that are entertaining to these COVID positive cases. So the treatment, before the treatment starts, we have to first make ourselves safe by proper donning of the PPE. Oxygen therapy, we start with low flow modalities through nasal cannula of 2 to 4 liters per minute. Whoever has an SpO2 of less than 90%. When you're giving nasal cannula, a triple layer mask is recommended to cover the nose and the mouth, unless the child does not tolerate it. And especially during transport, this is highly recommended. For infants, it's recommended we use the oxygen hood. It's a glass box that we place the baby's head in, and we just put oxygen tubing into it. So this will greatly help in the contamination and avoiding the contamination of the environment. Highly talked about yesterday, the HHFNC, that is heated humidified high flow nasal cannula. Ideally, you need a negative pressure room for starting these modalities. But when I say this, this is a luxury now. Even the most resourceful places are becoming stringent, and we don't have negative pressure rooms for treating COVID-19 patients. So if we have it, please, we should give priority of putting them in negative pressure rooms. Flow of 2 to 3 liters per kg with oxygen target for the desired SpO2. But this should not be tried for too long, maximum 1 to 2 hours. How do you see signs of improvement? There will be decrease in the heart rate, that is settling down. The tachycardia will settle down. The respiratory rate by 10 to 20%, it may settle. There's a decrease in the F-FITO requirement. Mostly, we should target something less than 50%, and improvement in the oxygen saturations. Patients with impending respiratory failure, please go ahead with early invasive mechanical ventilation. Non-invasive ventilation, again, this includes all the modes, CPAP, BiPAP, NIPV, everything in it. I'm not going to details of it. The professional societies recommend against use of NIV for acute respiratory failure, particularly in severely ill patients. So it is it recommended for COVID-19? Yes, when you have a mild to moderate disease process, not when you're having a severe disease process. It is accepted as a high-risk procedure because of the aerosol generation. But again, it's a controversy. How much of it is getting affected? Is it actually really causing COVID transmission to the healthcare workers or to the surrounding? It does have aerosol generation, but does it really make you positive when you are caring to the patient? We are still to clarify this with future studies, hopefully. Routine use of NIV is not recommended for COVID-19. Ideally, again, either negative pressure rooms are required only in selected patients with hypoxemic respiratory failure. As I said, it is recommended to use only in mild cases who are hemodynamically stable. Selection of interface is the key. Unlike adults, you have small, medium, large masks or helmets. But if you go for pediatrics, you have a huge age group and you have a huge morphology or anatomy to cater to. So when I say small mask, medium mask, it does not, it may not fit. Even the same 4-year-old, it may not fit all the 4-year-olds or a 14 kg person. So, getting an interface for the NIV in pediatrics and neonates is a challenge in itself. Now, in COVID, we need to make sure that if a helmet can be used, perfect. Total face mask, very good. Oronasal and non-vented mask is the ideal. How they tolerate it, if they tolerate it, is a great question of matter. And getting it to be fitted right is a challenge in itself. We should have a clear plan for treatment failure when you're starting with NIV, because this may fail. then, as it was mentioned in the first talk, no emergency planning, no emergency intubations. You should have a plan for what should you do if this is going to fail. As again, asserting on what I said, there should be a protection, a plan for planned manner of care. So there should be a good protection for the healthcare workers. Risk of NIV is that it will definitely delay intubation. It will cause large tidal volumes and also be injurious to the transpulmonary pressures, which will worsen the scenario. You have to use double limb tubing for NIV in COVID cases. You have to use the bacterial filters, which has been already talked about. Home ventilators can be used. Another thing that can be used in the pediatrics and in the neonates is that use bubble CPAP if you're not having these sophisticated machines, or if you want to escape from the oxygen therapy. So bubble CPAP is a simple setup where you can just immerse the expirated limb in water and you can get a pressure that is given to the that is transmitted to the child's chest, which will give some amount of PEEP to the child. So expirated filters are very mandatory to use when you're using these conventional ventilators. This is what it looks like. I'm sure it has been already mentioned before in the previous talks. Intubation, I'm not going into detail of it, but yes, it is to be done as early as possible. Criteria is less than 300 PF ratio, worsening trend of SP by Air2 ratio, or less than 200, oxygen requirement more than 60%, and multi-organ dysfunction. If there's presence of all these, please go ahead with intubation. It's a highly aerosol generating procedure, so we have to follow the guidelines of video laryngoscopy or having a barrier device, and protect ourselves also during this procedure. What are the equipments required? I'm not going into details of it because it is well explained in the previous talk. But what I will assert here is that COVID-specific things for intubation and mechanical ventilation. Video laryngoscope is recommended if you have it. Micro cuffed endotracheal tube or cuffed endotracheal tube. This is also being changed in the PALS 2020 guidelines that you only will tube with cuffed tube henceforth and not with uncuffed tube anymore. So you have to use cuffed endotracheal tube. Closed inline suction, if available, please only use closed inline suction. If you do not have it, you have to make sure that if you're going to suction, open suction for the child, you have to give a neuromuscular blockade and then go ahead with suction. The other major differences I'm not going into because it is well explained in the previous talk. And another thing is about pre-oxygenation. Pre-oxygenation, it is said that not recommended in COVID cases, but in children and in neonates, they may not tolerate an apneic phase, or they're already in such bad hypoxia, they may not give you the time. So you may have to pre-oxygenate them. If you're pre-oxygenating, make sure you make a very good seal and may have a plastic barrier, like I will show you in the following pictures. And make sure that you don't create aerosol generation towards the person who is giving the bag and mask ventilation. So you have to have a filter between the mask and the ambu bag. You have to have a plastic barrier. Now, how much this prevents aerosol generation, we don't know. We don't have a value data on it, but to some extent it may. But it may also delay your process. It may also make your your process of intubation prolonged. Your ineffective ventilation may happen because of all these barriers. Putting a plastic cover over the intubation, or putting your doing the intubation under something called as, this is a bigger version of an oxygen hood, something like this. But again, it all depends on how your institute, what your institute or what your team have consensus on to follow. It is not easy to do under these circumstances even for the most skilled people. So it all depends on what your team wants to follow or what your consensus are on. Ventilator should be in standby mode and not be turned on after, and only be turned on after connecting to the patient. Prior to connecting to the ventilator, the tube has to be clamped and attached to the viral filter. This also has been mentioned so that you prevent the aerosol generation out to the environment. Ventilation strategies, Ms. Ruchita has very nicely explained us the ventilation strategies for ARDS. So I'm not talking anything more on it, but It's a similar thing that you would do for parts for the pediatrics ARDS. It is nothing too different. You would want to maintain the platelet pressures to 28 to 30. You would want to give a good PEEP. You would liberally oxygenate, and you would give tidal volumes of 4 to 6 ml per kg. And you would keep the person, the child, properly sedated, and so that the ventilation can happen without any adherence. Other strategies that are recommended is trial of inhaled bronchodilators. Nitric oxide has been reported to be tried so that it decreases the pulmonary vascular constriction and can help in our oxygenation. Recruitment manual, yes, of course, it is very much followed, but how much in pediatrics it is helping is something that we have to still wait and watch, and how much and how well to give it. ECMO, yes, another strategy that can be followed to save the COVID patients, but no data to tell you that this is the criteria to follow for COVID patients. What we do in ARDS, we are doing in COVID. Weaning and extubation is, again, if your PF ratio is above 300, you're weaned of all the neuromuscular blockade and sedatives. You can extubate to a nasal oxygen preferably. So as Rujita said in her case case 1, they were happy to bring the patient out to HFNC. So that's a clear-cut example of across age groups that is what is preferred. And fewer units are, when you extubate with a plastic sheet over it so that you prevent dispersion of the aerosol coming to the healthcare workers around the patient. So this is how it is done. Again, this is in some places they fill this plastic cover with oxygen so that the person is extubated to an environment of 100% oxygen. So these are things that you can modify according to your available resources and according to your team consensus, of course. So what are your takeaway points here? Low flow oxygen devices are most commonly preferred for pediatrics, and most of our pediatrics will settle with this low flow oxygen therapy because they don't get that sick. High flow nasal cannula and NIV, mild to moderate cases only. You should have proper donning of PPE because aerosol precautions must be taken. Early intubation mechanization is recommended to delay the progression and the need for emergent intubations. There is a risk to healthcare workers here. So I'm keeping on asserting this, that risk to healthcare workers is something that we should beforehand and take it as priority. Lung protective ventilation with liberal sedation, that is with analgesia and avoidance of steroids. So these are some takeaway points for the COVID-19 patients, especially in the pediatric group. Thank you.
Thank you. Thank you very much, madam, for your wonderful presentation. So now we have our fourth speaker, Ms. Momita Chakrabarti, with us. She has done her graduation and post-graduation in respiratory therapy from Symbiosis International University. Presently, she is working at Narayana Institute of Medical Health Sciences, Bangalore. Today, she is talking on pulmonary rehabilitation in post-COVID-19 patients. Over to you, madam.
Good evening, everyone. Thank you for giving me this opportunity. Today, my topic is on the pulmonary rehabilitation in the post-COVID-19 patients. First, we will see what does pulmonary rehabilitation mean. Before that, I have a disclosure statement that I have no affiliation, financial or institutional benefits, or conflict of interest to disclose. Some of the views expressed in this presentation are subjective to the evidence-based practices and anecdotal experiences that are currently available in the literature. So this is the standard definition which has been given by various bodies. Pulmonary rehabilitation, it is an evidence-based, multidisciplinary and comprehensive intervention for patients with chronic respiratory diseases who are symptomatic and often have decreased daily life activities. So mostly pulmonary rehabilitation was instituted for chronic lung diseases such as COPD. But as of now, we have seen that pulmonary rehabilitation can benefit the patients who has recovered from a COVID-19 infection, especially who had been on ventilatory support for quite a long time. Integrated into the individualized treatment of the patient, pulmonary rehabilitation is designed to reduce the symptoms, optimize the functional status, increase the participation, and reduce the health-related cost. That is by the stabilizing or reversing the systemic manifestations of the disease. So we know that a patient who had been on ventilator for quite a long time, post ventilation, and once they are back to the normal life, in the case where they had actually suffered for such a long time, it is very difficult for them to get the same quality of life again. So they would have not only a component of physical disabilities, but also they would have a component of cognitive disabilities. So this is one of the European Respiratory Journal. It's a journal which states that the high burden of respiratory, physical, and psychological impairment, which has been seen in patients post-COVID-19, it is always better to send them for an early rehabilitation program. And somewhere by doing that, we are also preparing ourselves for the phase 3. Post-COVID-19 lung-related impairment. So why are we considering pulmonary rehabilitation in post-COVID cases? So there are 4 important points that has been found, one being the lung function impairment. So the lung volumes and capacities are highly reduced. So when there is a decrease in the lung volumes and capacities, definitely oxygenation becomes a question. The lung suffers from a restrictive pattern of ailment. Impaired exercise tolerance. Especially there would be a decrease in the activities of the daily living, which is attributed to dyspnea and hypoxemia. The patient would complain of dyspnea, due to which he or she will not be able to do his activities of daily living in a proper way. So that's the reason why even psychosocially socially also he would be deprived. Lung fibrosis post-recovery. Some of the papers, the research papers or the case studies have shown that post-COVID-19, there are microatelectic changes to the lung along with interstitial fibrotic changes. So all this indicates that the lung would have a kind of a restrictive pattern of the kind of impairment would be of a restrictive pattern. And all this would further lead to decreased quality of life. And that is why we are concerned of how to make sure that the patient would live a near normal life even after the COVID-19 infection. As you can see, this is a research paper, and where they have actually found that there is a significant loss of lung function, which is related to the severity of the radiological lung involvement at admission. Yes, this is one more study which has found that lung fibrosis is a worrisome sequelae in surviving patients. So here, pulmonary rehabilitation plays a very predominant role. And we all know that rehabilitation is not just of one branch, it is a multidisciplinary branch. So it is not just that the respiratory therapist would be involved, even the physiotherapist, the occupational therapist, the speech therapist, even we also have the swallow therapist. Because if a patient had been tracheostomized, a thorough course of swallow therapy is required so that weaning becomes easier, decannulation becomes easier. So it is a multidisciplinary approach. So where can we institute a pulmonary rehabilitation program? It can be post-COVID ward, which is there in the hospital, or it can be transition care facilities. There are many facilities, they are not exactly hospital and they're not exactly home. So in between, the patient can go for a transition care facility. And yes, definitely the home care. And we also have the tele-rehabilitation. Now, all this are the places where pulmonary rehabilitation can be instituted. Now, telerehabilitation was present before on, but now we can use it because most of the respiratory therapists are on field. If you see, everybody is on COVID duty and we do not have time for home visits. So telerehabilitation would help us to not only monitor the post-COVID patients, but also to equip them with various exercises, with various training, like breath training exercises that would help them to overcome the dyspnea which they are facing in their daily life. Now, pulmonary rehabilitation is a very goal-oriented approach. We will always focus on what goal the patient wants to achieve for himself. Like, for example, if I have dyspnea and I have difficulty in working, and my priority is to get rid of only dyspnea, that is the goal where my therapist would take care of. So it is very goal-oriented, patient-specific approach. So these are the 4 goals which we can basically focus on when we are doing a rehabilitation in case of COVID-19. That is reduction of dyspnea, strengthening of the ventilatory muscles, restoration of the lung volumes and capacities, and the secretion clearance. So these 4 are basically the main areas of concern, and these 4 would be our target for the pulmonary rehabilitation. Ultimately, all at the end, the aim is to improve the quality of life. Now, what are the stages of an integrated PR program? The first stage is the baseline assessment. So whenever we think of going for a rehabilitation program, or when we are actually incorporating a patient for the PR program, first would be the baseline assessment. That is, we should know whether the patient is rehabilitable or not. Like, there are cases where the patient is the age is quite very old, like 90, 95-year-old, or is suffering from an end-stage disease, might be a cancer. So in those cases, the efficacy of PR will not be really good. So that time we have to think whom to include. And the physicians would actually tell us that you can take this patient for the rehab program. So that is the baseline assessment. Then we have the development of a holistic care plan. So when I say care plan, it does not just mean, as I told, it's not just one branch. It would be a collaboration from all the branches, from nutrition to psychology to rehab, pulmonary rehab, everything. And from there, we would start to finalize each and every week's program. The third is implementation and adherence to care plan. It is not that you would teach some exercises to them on day 1 and leave them till 6 weeks. It doesn't happen. You have to keep on monitoring them. Because if you're not monitoring them, there are chances that the patient would just not care to take up the exercises or whatever has been told to them. So implementation and adherence is a must. And last is the outcome measure. When I say outcome measure, it means that I have to find out whether the rehab program was helping the patient or not. It is very similar, you can say that week 0, when we first assess the patient, what was his condition? And after the rehab program, how his condition has been. And we would see whether there is betterment or not. So for outcome measures, we cannot be having a subjective data. Somewhere we have to quantify, like it should be numbers, so I can calculate whether my PR program was better or not. So that's why there are certain variables which a respiratory therapist should learn when we are thinking to work for a rehab program. So what are the stages of an integrated PR program? First, as I told you, is the baseline assessment. It is very, very important to have a very clear, crystal clear baseline assessment. If the patient is rehabilitable, is there comorbidity? Because it might be the patient is a case of post-COVID-19 pneumonia and is also having COPD. How do I initiate exercises then? Because a restrictive pattern and an obstructive pattern are very different from each other. So if I have given some exercises to improve the restriction, it might cause breath stacking. And if I have given some exercise to relieve the obstruction, it might cause some other more restriction, and some other issues. So that's why having a clear knowledge of comorbidity is very important before we start with the rehab program. Then we need to check the ventilatory muscle strength. I'll let you know about each and every parameter as to how to quantify it or how to find it out. Sustained maximal inspiration, walk test, dyspnea scale, and whether the patient requires a secretion clearance therapy. So as you can see in the right, this is the baseline variable chart. First day, when the patient is ready to be incorporated in the program, we check for oxygen need. Is the patient on oxygen? How many liters are required? Second is whether the patient has any artificial airway in situ, especially they might be having a tracheostomy. What about the peak cuff flow? Just to know about their cuff effort. Then what is the maximum inspiratory pressure? So how do I get the maximum inspiratory pressure or the maximum expiratory pressure? So a very easy way of getting it is, there are two ways. One way is to use a pressure gauge. Take a normal pressure gauge, the one which you find normally in anywhere, and attach a mouthpiece. Ask the patient to have 3 readings, like ask them to take deep breaths 3 times, okay, and take the mean of it. Once you get the mean of it, you will understand what is the maximum inspiratory pressure. Because even on ventilator, you do not have any option to find the PI max. You can find the flows, but not the pressures, except the negative inspiratory pressure, NIF, those you can find. But post, like after weaning, how do I get it? So pressure gauge can be one of the ways. Second ways I will discuss in my upcoming slides. Second is sustained maximal inspiration. So this terminology or this term, or you can say this index, is basically predicting the lung volumes. So you can use the incentive spirometry to know their baseline value. Then you have the peak inspiratory flow rate. So I will show you the device from where we can find it out. Various spirometry indices, that is your FEV1 FVC, PEFR, FEF 2575, FEV1. All these indices would let you know regarding the lung functions and the capacity of the patient. Then we have the certain dyspnea scale, like the modified box scale. Then 6-minute walk test. I think you all have seen, whoever is working in the clinicals, you must have seen that there is something called a 6-minute walk test done in the pulmonology department, or there are certain shuttle walk tests also. So they would give you an idea regarding how good the patient is to participate in his daily life activities. So that value can be taken. Single breath hold. Now, single breath hold is nothing but deep inspiration and how much they can hold it for how many seconds. That is important to basically know regarding how well then they can take the inhalation therapies. And also they would it will also suggest how good is their functional residual capacity. And then we have other parameters of PFT like BLCO. If at all it is done, you can take the value. But what is the challenge here? This is what we do for other rehabilitation programs. But what about COVID? They all might be aerosol generating. So when it is like, even if the patient has completed his quarantine period and has now been given rehabilitation regimen, you can say, but still there is slight chance of they still carrying the viral load. So the best and the most important thing is we have to make sure that the professional who is interacting with them has to have a PPE and certain barrier devices, which I will discuss in the upcoming slides. So these are the devices. These are the ventilatory muscle trainer. As you can see, the first one from the left is the IMT threshold device. The second one is the EMT, that is your expiratory muscle strength trainer. The third one is the third and fourth one are the P-flex inspiratory muscle trainer. So when I say muscle trainer, like every other muscle of the body, we need some weight or we need some load. So IMT devices also have some load. They have some resistant point against which the patient will inspire and expire. So when they do it on a regular basis, they are targeting the inspiratory muscle, like your external intercostals, your diaphragm, your pectoralis. All these muscles would be activated, because when you have been on a ventilator for such a long time, there is somewhat some dependency. So you need to activate those muscles of respiration. We have to remember, till the ventilatory muscle strength is good, we cannot achieve good lung functions. We cannot achieve the appropriate or near normal lung functions. So we have to target on ventilatory muscle strength. So these are the devices. Once you see it in your clinics, you will be better acquainted to them. So all of them has just one way. You just have to keep on increasing their resistance. So that's how we would train the patient, and we will increase the set. Like, for example, if there is a patient and I have started with these devices, maybe on day 1, I will ask him to do it 20 times. After a week, I will escalate it from 20 to 30 times and 2 times in a day. That's how we would make them do it on a regular basis, so that their ventilatory muscle strength would be better. Now, these are the screening tools. They are not used for training, but they are used for screening. So as I said, when I take the baseline variable, I need to screen, right? So the first one is the PIFR. So PIFR is basically showing you what is the inspiratory flow, the peak inspiratory flow. So that becomes your baseline on the day 1. Then every week, or maybe twice in a week, you can take this reading. Similarly, you have the peak expiratory flow rate. So peak expiratory flow rate is a screening tool which has been used enormously in cases of asthma to know the benefit of the inhalation therapies. But just for the baseline purpose, you can definitely take the reading from this. But they are definitely not training tools. And since if you are just seeing for COVID-19, it has a very restrictive pattern. So we will avoid certain exercises which will lead to loss of volume, like force expiratory training exercises. We will not go with that. Now these devices, this is the SMI devices, that is sustained maximal inspiration devices. Their main work is to restore the functional residual capacity to near normal. So I think everybody must have seen the incentive volumetric spirometry, but we also have something called as EZ peak expiratory pressure, positive expiratory pressure. So in this device, you can see that there is a manometer, like the pressure gauge, you can see it is attached, and the oxygen port is attached. So they would help the patient to basically increase the functional residual capacity. And when you breathe in and out through this, the areas of the lungs which are having collapse, like your microatelectasis, that would be resolved. But if the patient requires oxygen, you can use it. So you can use maybe 2 liters with this, and you can use with nasal cannula. If the patient requires more than 3 liters of oxygen, that can be done. This side you can see it is the incentive volumetric spirometer. Even nowadays, you can get the customized one where the oxygen port is present. So you can institute oxygen if at all the patient requires, and also to avoid exertion. So these devices would help you, mimic the natural sighing mechanism of the body. Then another very important factor is the secretion clearance. If the patient is on artificial airway, that is tracheostomy, yes, you can do the suction. What if the patient is decannulated, doesn't have a good cough effort, his cough effort and his cough reflexes are poor? What do we do with them? So one of them which can be used regularly is a vibrating percussor. So a vibrating percussor, it is somewhat more comfortable than manual CPT, that is a chest preserve therapy, because patient may not be, especially if they are on a home care, they are not very comfortable with the manual chest PT. So that time this percussor would help if you can maybe utilize it for twice a day. It would help. Along with that, you can retrain them. You can build their cuff effort using the devices such as, so these two devices are instituted to definitely mobilize the secretion. So when I say mobilize the secretion, basically the flutter device, it has a metallic ball. When you breathe in and out, that ball vibrates and that creates the vibrations. That vibration would help to mobilize the secretion. And somewhere when you're using the acapella or the flutter, you are also retraining the neck muscles. So your cuff effort, also your swallow effort would be better. So there are certain studies which have seen that these devices not only help in retraining the patient to cough, but also helps with the swallow therapy part. So these are some of the devices. One of the devices which I have not included here is the cuff assist. So the cuff assist is a machine where it has a mask. You just have to set the oscillation and the mask will deliver the vibrations, provided patient doesn't have a contraindication to that. So that is one of the device which can be used. Along with the devices, definitely you need to teach them certain retraining exercises, like the single breath hold, segmental breathing. Now, segmental breathing is, as you can see in the picture, the red color picture, you can see the patient has tied a TheraBand around him. So this is the lung segments. So he will try to breathe against this resistance. This would help him to open up the areas of atelectasis, if any. Next, you have the diaphragmatic breathing. So you can see again in the picture, what we have done is we have placed a resistance over the, just below the sternum at the diaphragm. So when you're breathing against that, you are strengthening your diaphragm. So that's how whenever your diaphragm is getting strengthened along with your external intercostals, your serratus anterior, your pectoralis, all will help you to take more breath and to relieve the loss of lung volume, which has happened because of the entire event of ventilator and everything. Then we have other techniques like huff cuff technique, AC, your active cycle of breathing technique, breath stack technique. So these you would see practically with patients. But as of now, I would suggest that since in this COVID era, it's better we do not go for these techniques because they are very highly aerosol producing. So once the patient comes home or the patient goes to a transition center or after the ISU event, he can be started in very minimal resistive exercises like the single breath hold, segmental breathing, diaphragmatic breathing. So once you start it and the patient is quite able to maintain and he's quite able to do it, then slowly you can go for the huff cuff techniques. Now, as I told you that everything is fine, but what about aerosol generation? We are still not very sure regarding the viral load. So there are techniques like using, like you can see, this is an incentive spirometer, which is customized and can be used with a tracheostomy tube. So a filter can be attached. And the other side, you can see the patient, he's using a PAP therapy device, and again, a filter is instituted. Along with that, screening devices are good, like you can use a screen and let the patient do the breathing part or the exercises part. Do not get very much involved in the same place. That will be better. And always you have to be on mask. So these are some of the ways which would help you for preventing the aerosol generation. Same thing can be taught to the relatives at home also, because when we start the rehab program, it is not just a month or two, it can go for a year. So that time it is very important to counsel the patient's relative, because they would be making him do it every day. So these things we have to keep in mind. Also, one more thing I would like to say is that when we are using incentive spirometry, we have a tendency to even for expiratory muscle strengthening purpose, like the flow one you must have seen. We'll just turn it and we'll make the patient blow out with full energy. But if there is a case of epilepticus and you're using that, it is really hazardous. Why? You are making the patient lose his lung volumes. Incentive is made for the inspiratory flow or the FRC to get restored. So it's always better not to use the incentive for expiratory muscle training. You can definitely use EMST, you can use bed stacking methods, those would help you instead of using the flow oriented incentive. So I've seen that very common with patients who are in ward, where we just reverse the incentive and make them do the expiratory flows with full force. That is really hazardous to the patient. Now, how does a PR regimen or a program like? So 6 months is the standard time. It might go up to 1 month, 1 year or more than that even. The first 3 weeks becomes the initial phase, while the next 3 weeks becomes the maintenance phase. So first week, like week 0, what you will do? Assessment. So you will do the baseline assessment. You'll do you'll go for the regular secretion clearance therapy, whether it is your manual CPT or your vibratory percussors. Then cuff retraining with the devices, low intensity non-resistive breathing exercises, and ventilatory muscle training. So that is what I showed you, the IMT devices which you can use. So I told you that we can obtain the PI max using the pressure gauge. So how do I start training? So best way, if I get a PI max of 25 centimeters H2, example, I got it in my pressure gauge. I will start training from a lower limit. That is, I can start from 20 instead of 25. From there, we will start the training. So that value is very important. Like from where have you started? The goal would be something above 40, 60, even more than that. But the IMT device has marking till 41. So our goal would be to finish that 41 centimeters H2. So we would start it with the lower level of the PI max. And the repetitions, yes, that is totally dependent on the patient condition. Whatever you feel, you can institute. There is no such guidelines for the repetitions. You can design the own repetition, seeing the factor of the age, seeing the factor of the illness. So accordingly, you can tell them that this many repetitions would be required for you to do, maybe twice in a day, thrice in a day, or maybe even 4 hourly, depends. Then the week 4, 5, 6 is where we do the escalation. We would increase the intensity, we would increase the endurance. For that, the same thing, but with a higher level. Whatever we have mentioned in week 1 to 3, same thing, we would increase it. So if the repetitions were 2, we would increase it to 4 to 6. If the PI max I was training was at 20, I would now train him at 30. If I was using the cuff retraining, I would increase the number of repetitions. If I have made him, I will institute a resistive band, like a TheraBand. Let him do exercises with the TheraBand, or a sandbag can be used. So those things we have increased. The level of difficulty is increased. After which, like if you think the patient is doing well, every week or maybe twice in a week, you have to just make sure that you see the patient. If it is a home care, you can go for tele-rehabilitation, or if it is in the COVID ward, you can definitely see the patient quite every day. Or if it is in a rehabilitation setup, make sure that you see the patient at least once a week. There you will understand that yes, patient is doing well, or whether the patient needs a dropout, because a lot of issues might happen due to which a dropout can be there. Maybe we missed the patient having a pulmonary hypertension during the baseline assessment. Patient is totally dyspneic. We cannot give him the high level intensity exercises. So those things also have to be kept in mind. Not every patient will benefit every week or in the same program. So if there is a dropout, leave it. Whoever is good enough, we would train those. And at the end is the outcome measure to find out whether my PR program was effective or not. Now, this is an example. It is basically what we have done is we have taken just one variable. The variable is the work test related dyspnea. That means after 6 minutes of working, what was the level of dyspnea? So we have a scale. I think all will know it is called as modified box scale, which we are using. We have a scale on week 0 on assessment. The patient was told to work for the 6 minutes, and we found that it was around 4. 4 means somewhat severe. His dyspneic level or his rate of exertion was around 4. So every week when we have seen or we have made him do the 6-minute work test and we tried to measure the box scale, we saw that after the end of 6th week, it's from the level 4, it has become level 1. So it is a subjective, you can say, scale. The patient will tell, okay, I'm feeling moderately dyspneic or I'm not at all dyspneic. Accordingly, they will mark 1, 2, 3, 4, like that. So we have found that from 4, it went down to 1. So this is just one variable, after which all the variables we can compute. So these are the different studies which has shown that pulmonary rehabilitation is possible and it is effective in patients recovering from COVID-19. Just that we have to keep in mind regarding the viral load which might be there. First and foremost being the counseling of the patient, the relative, because it's like after a week or so, they will just give it up. So counseling, repeated counseling is required and it is evidence-based. They would say that, okay, I might see some YouTube exercises and I will do it. There is no requirement for you, but you have to explain them. Each exercise that we are giving them is very much evidence-based and it is going to help him in achieving that goal. Like if his goal is to feel good and no dyspnea, this exercise is for that. So that way the counseling has to be done. And that is the major part. Why very less respiratory therapists are in rehabilitation is because counseling has to be taught to the professionals first. Then they can institute it, then they can teach somebody else. So it's very important that we learn the counseling part for the patient. Now, this is another review article. Day-2 have mentioned the same thing, that the current practices of pulmonary rehabilitation would be beneficial in this pandemic, especially the patient with post-COVID pneumonia patient who had been on ventilator. Definitely it would help. So with this, I end my topic and thank you for giving me this opportunity. Thank you so much.
Thank you very much, madam, for your detailed presentation. So we have next with us Ms. Anmol Thorbole, the 5th speaker in today's session. Ms. Anmol Thorbole, she pursued her bachelor's and master's degree in respiratory therapy from Symbiosis Institute of Health Sciences, Pune. Currently, she is working as a head of the respiratory therapy department in the Apollo Specialty Hospital, Jayanagar, Bangalore. Today, she is going to make a presentation on home care bundle for healthcare providers. Over to you.
Thank you. Good evening, everyone. Am I audible?
Yes, you are audible.
You're audible.
Okay. So thank you for such a good opportunity. Well, talking about the COVID-19, as we all know, that currently the scenario is totally changing. We can't even decide about what is going to happen next. So talking about home care, now this, as we know, COVID-19 has changed the healthcare spectrum completely. So nowadays, telemedicine, telecommunication, telehealthcare has even come into the picture. Everyone is scared to come to hospital and provide and take a consultation. So in such scenarios, the COVID-19 has helped us to move to home care setup. Initially, we had this home care setup only for the patients who were chronically ill, who were on long-term ventilation or long-term NIV, such as in cases of COPD. But now that it has spread it over through the broad spectrum, so let's talk on to it how we are going to manage our COVID-19 patients post-discharge or the minor cases. So for the disclaimer, I have no personal financial benefits to disclose. Second thing, who is eligible for our home care first of all? So asymptomatic cases who has been tested positive with COVID-19. So for them, only thing what we have to do is isolate them and then wait if any symptoms occur. Second is mild symptoms without any risk factors, and the risk factors include age below 60, more than 60 years, diabetes, hypertension, chronic cardiac or liver or kidney or respiratory diseases, cancer, or any old history of stroke. So for symptomatic or mild symptoms of COVID-19, what are the symptoms? What we have to look after? First is fever over 100 degrees, persistent fever. Second is cough or sore throat. Sudden onset of a shortness of breath, then chills, new muscle pain, any loss of smell or taste, nausea, vomiting, any diarrhea, headache, excessive fatigue, congestion, or the runny nose. So these are the symptoms of COVID-19 for mild patients. So what and how to monitor at home? So first of all, monitor the symptoms, how minor they are. Get all the tests done. Second is monitor for oxygen saturation with a pulse oximeter. Monitor your heart rate and ask the family member to perform a 6-minute walk test, or else you can ask the patient to perform a 6-minute walk test just before your consultation. So this is the monitoring chart which has been prescribed by Ministry of Health and Welfare in India. So this is the monitoring chart which we are using for the patients who are at home for mild COVID or post-COVID. So in that they have to mention day of symptoms and time every 4th hourly. Then second is they have to mention their temperature, then heart rate, saturation, if they're feeling better, same or worse, and if the breathing has been better, same or worse. In same manner, they have to monitor it every 4th hourly and get the consultation done. So how to monitor pulse oximeter at home? So what the target saturation currently for the COVID-19 is more than 93%. If saturation shows suddenly less than 93%, first of all, don't panic. Remove your pulse oximeter. Rub your fingers to make them warm. Because sometimes if the extremities are cold, even at that time you can feel that saturation is low. So check in at least 2 different fingers. Leave the oximeter on the finger for at least 2 minutes to note the final reading. If still less, walk for 3 to 2 minutes and recheck it. So what is 6-minute walk test? For the RTs, as they know what is it. For the ones who don't know, so what we do is check a baseline oxygen saturation. Make the patient to take a brisk walk for 6 minutes and recheck the oxygen saturation post 6 minutes. What are the warning signs for that? If saturation falls by more than 4% or if saturation falls less than 90%. So that is an alarming event. So when to seek help? When you are in home quarantine. So when are you supposed to seek help? First, when oxygen levels are less than 92%, when you feel excessive fatigue or drowsiness, excessive non-stop cough, if you feel sort of chest pain, any breathing difficulty, if you have a cough with expectoration, and if you find some blood in the sputum, in such scenarios, if there is a confused state of mind, or whenever the heart rate is more than 140 or below 60. So what are the precautions for the patients to take at home? First is isolate the patient. Contact any other family member only while wearing a mask. Maintain at least 2-meter distance. Reduce contact time to less than 5 minutes. And no need to wear mask while you are all alone in the room. What if oxygen level suddenly starts falling? So first of all, when you see, okay, your oxygen levels have started falling, don't panic. Seek an urgent medical help. Try and get admitted to a hospital or any COVID care center where you will find oxygen supply. In the meanwhile, you do all this thing, you can do is sleep in a prone position as long as possible. Perform deep breathing exercises or incentive spirometer. And keep checking your saturation. So now home oxygen management. In some of the scenarios, when, as we know, previously we had a very bad status going on in the state for the beds were not available. If beds were available, then oxygen beds were not available. In such scenario, what are we supposed to do is source an oxygen device if possible. Either it is concentrator or cylinder. Perform awake proning. Awake proning has been talked by Dr. Parimala yesterday, so I won't go into detail. Perform awake proning. Perform deep breathing exercises such as incentive spirometer. Seek medical help. Get medical consultation done. And most importantly, keep calm. Do not panic. So this is how you can change the positions based upon like 4th hourly or 2nd hourly as based upon your comfort. First is lying on your belly, which is in your prone position. Then you can turn around for and lie on your right side for 2 hours. Then you can sit up in a proper position. Then lie on your left side and then again go back to prone. In this way, you can keep turning your positions. This will help improvise your oxygen levels. So now how to use oxygen devices, concentrators. Recently, when I have gone through many online consultations for this respiratory therapy thing, so we get most of the patients will be asking this common question, such as like how to use concentrator, because all the people, they don't know how to use it. What is the basic step?
Message ಮಾಡಿದ್ರು sir, closing remark.
So first of all, position the machine 1 to 2 feet from away from the wall. Second is connect the humidification bottle as it is labeled in the figure level number 4. Make sure the air filter is in place. Attach your oxygen tubing to either the humidification bottle or an adapter, which is labeled as number 5. Start your oxygen concentrator at least 15 to 20 minutes before using it by plugging in the power cord. This is done by the switching the power button on the to the on position. So the level number 2 shows you the power button. Once you plug in, just turn it on. Second is fit your nasal cannula upward into your nostrils. Note position behind the ears and tighten the chin. After that, adjust the knob to prescribed oxygen level. If it is a 5-liter humidification, 5-liter concentrator, so you can adjust up to 1 to 5 liters. And if it is 10 liters, then you can adjust up to 1 to 10 liters. But before using it, please contact your healthcare provider. So what measures you are supposed to take while using oxygen? First of all, titrate oxygen sitting to the maintained saturation levels around 92 to 94%. Higher oxygen levels may not be more helpful. Try and keep oxygen to the lowest required setting. Please use a longer tubing and use oxygen while exertion, example using the restroom, bathing, or etc. Keep a track of oxygen requirement. If requirement is persistently increased, please get yourself admitted to the hospital as soon as possible. So generally, after this oxygen thing, most of the patients who come to our hospital, they depend on the NIV for at least for the overnight setup or some intermittent NIV support. So in such scenarios, we prescribe the patient to discharge on NIV, and then we might follow up to reduce it, tighter the NIV settings accordingly. So many patients require NIV or supplemental oxygen or both post-discharge from the hospital care. The patient discharged on non-invasive ventilator require frequent follow-ups and adjustment of NIV settings based on clinical status. NIV and oxygen support is usually titrated to achieve normocarbia. So normocarbia is the carbon dioxide levels within the normal range. a saturation of 92%, and an optimal work of breathing. Involvement of respiratory therapy services can optimize NIV management and faster weaning even at home. So how the steps to connect NIV are: place the machine adjacent to the bed, connect the tubing and mask to the machine, press the switch button to turn on the machine, place the mask from the nasal bridge covering the full face as shown in the figure. Set the machine as per the patient's demand for respiration. Keep checking the saturation and work of breathing. And ask your healthcare provider to adjust the settings according to the patient demands. Once the patient is settled, even after 2 hours, you can get an ABC done at home itself. Now, there are some patients who are having fibrous lungs, which are very difficult to ventilate them, wean them off the ventilator. So we need to provide them ventilator even at home. So for such patients, we can provide portable ventilators at home and a respiratory therapy support to monitor the settings and titrate it accordingly. So few patients have continued ventilator dependence after the acute phase of illness have resolved. These patients constitute less than 10% of all patients requiring invasive mechanical ventilation, but consume more than 40% of ICU resources. These patients can now be discharged home with high level of care provided by skilled nurses, respiratory therapists, and trained physicians. Frequent ventilator adjustment, care of tracheostomy site, and other invasive catheters require high-end monitoring and frequent follow-up. For such patients, we can do for continuous monitoring, every consultation after 3 days. So, and the settings and all, we won't go in brief as it will be prescribed by your physician according to the patient's ABG and patient's work of breathing and respiratory mechanics. So what are the take-home messages for us? No need for hospitalization for all and every positive case, first of all. Second thing is, do not panic. Then early prone positioning helps a lot. Deep breathing exercises aid in improving oxygenation. Seek medical help at earliest. Remember, let's help patient who actually requires hospital care. Thank you so much.
Thank you very much, Madam, for your presentation. So with this, again, now we have the final presentation for this workshop. So we have Mr. Musallam Al-Nasir. Musallam Al-Nasir is a lecturer in Respiratory Care Department and head of the Simulation Operation Unit at Prince Sultan Military College of Health Sciences at Tehran, Kingdom of Saudi Arabia. Mr. Al-Nasir earned his master's degree from University of Texas Health Sciences Center at San Antonio. He is specialized in virtual medical programming. He is a certified simulation specialist and one of the key members of the Excellence Center of Advanced Simulation at Prince Sultan Allied Health Sciences College. Over to you, sir.
Hi, can you hear me?
Yes, yes.
Okay, good. Thank you so much for this kind introduction. It's my pleasure, to be honest, for this kind of invitation or giving me a chance to present for such a huge community in India. So let me share my screen. Okay, so I will try my best today to apply or demonstrate what the other presenter has talked about. Like Ms. Rajota, she already covered the initial setups or the initial ventilator parameters, and just to make it applicable, we need to use the simulation for this regard. So I will try my best today to apply what they already talked about in regard of the parameters and the alarms and etc. So this is a disclosure statement that I have no affiliation or financial or institutional benefits or conflict of interest to disclose. So I will start with a brief intro. I know like most of the presenters, they already covered why do we need mechanical ventilators and what are the importance of mechanical ventilators. But I will try today to emphasize on two main things that I will consider them are important to understand before starting ventilate patient. Which is the type of respiratory failure. Because based on the type of respiratory failure that the patient that he has, we will, we will choose which parameter to manipulate or which parameter to change. The other thing is the ventilator parameters and alarms. And what do we mean by ventilator parameter is the respiratory rate, huddle volume, and the PIP pressure if it's on pressure control. PEEP, which is the positive end expiratory pressure, and the I time, and all the parameters that is important for for the ventilator to function well and to keep our patient very safe. The first thing I want to emphasize on is the type of breath delivery. If we understand the breath delivery, we will have the ability to identify from the graphics that I will show you later on in this lecture, inshallah, which kind of breath is my patient breathing. And mainly, most of the ventilator has three things in common, which is the type of breath. Either it's mandatory by the machine, or assisted or triggered from the patient to the machine, or it's going to be all spontaneous, whether with a little help from the machine or without a little help from the machine. So the first thing we need to understand is the trigger. And what do we mean by trigger? And just to make it very simple, the trigger is who will start the breath, whether the patient will start the breath or the machine will start the breath. So each breath or each type of breath has different mechanism and who will trigger the breath. And mandatory and assisted breath, in the mandatory breath, the machine will have the trigger. And for the assisted breath, the patient or machine, one of them, they can trigger the breath and they can start the breath. The last one is the spontaneous. The spontaneous breath is when the patient, he will breathe by himself and he will take the breath as much as he can based on his muscles. And the machine either will help him or will keep them on the PEEP level. I will try to make this presentation very simple since we have a variety of audience. And I just have 9 slides. I will not take very long time here since my session is mostly on simulation. I have, I think 4 or 5 simulations, a program that I will show you to make the best understanding. The second one is the limits, which is either how much pressure I want the machine to deliver or how much volume I want the machine to deliver. And the last one is the cycle, which is who will end up or who will end the breath, whether the machine or the patient himself or time or whatever. So this is as simple as I can explain it for those three terminology. So now we'll talk about the most common things. I consider the ventilator as cars. Like we have different brands of cars, but if you learn on how to drive one car, you can drive any car regardless on what are the extra specifications that car has. As long as you know the most common things, or as long as you know the concept or the principle of how to operate the car and how to shift the gear, etc., you can drive any other car in the market. So here is a similar thing we have with the ventilator. If you know the most common ventilator modes, you will have the ability to work on any ventilator on the market, regardless different name, because ventilators companies tend to change the name of the mode just for like marketing purposes and etc. So the most common things that we have in the market is either the pressure control or volume control. And Ms. Rajota, she extensively covered the differences between those two modes, but I will just emphasize some points on those modes. So in the pressure control, we have a preset fixed pressure with variable volume and free flow, since we cannot control the volume, and the minute ventilation is variable for the same reason, for that we cannot control the volume. And in volume control, we have a preset fixed volume. We are the one who will set the volume, and all of that based on the idle body weight of the patient. And because we are controlling just the volume, the pressure will be variable, and the flow will be also preset, since we are controlling the volume too. And it is the same thing for the minute ventilation. Since we are controlling the volume, we know how much volume we have, and we can multiply that on the respiratory rate, then we will have an exact minute ventilation that we are seeking from our patient. And this is a brief like a graph on how to differentiate between volume mode and pressure mode from the ventilator itself. And I will show you, inshallah, in the next minutes how to differentiate it in real life. So the main difference between volume and pressure is the shape of the pressure waveform. If you can see here, I don't know if you can see my cursor or my mouse, but here in the pressure mode, it's very square, while in the volume mode, it's ascending form. And as I think Mr. Jota, she mentioned that the plateau pressure is so important pressure to measure or to keep in your mind, because in COVID-19 patient, the patient tend to have high plateau pressure and more than 30 centimeter of water. And usually once the alveoli pressure exceed 30 centimeter of water, it will be very dangerous on the patient lung. So the only way to measure the plateau pressure is to use a volume mode, or the main way to measure the plateau pressure is to switch the patient or to keep the patient on volume mode, and this is the plateau pressure that we are talking about. So here are the parameters that we need, and this is in general. I'm not talking in specific, but this is in general in case that we have decreased carbon dioxide or increased carbon dioxide, or decreased or increased oxygenation. If this is our desired goal, we can manipulate those parameters in for the sake like increase or decrease the oxygenation or ventilation status. Now we'll start doing the simulation session. I will start with the most simple program, then I will end up the session with the most complicated, not complicated, I mean the most smart program, which has all the ability to solve problem and that kind of things. And we will end up with a case scenario. So let me now switch the presentation. Can you see the screen for the ventilator? Can someone answer me, please? Okay, good. Yes. Okay. This is one of the most common ventilators that we are using here in Saudi Arabia, which is the Hamilton G5. And this is the real interface for the ventilator, and this is how it looks like. And usually all the ventilator, if you finish the BRIOS check and everything that's related to the ventilator maintenance, we'll start having this screen, which will give you the option to choose whether male or female. And based on that, we will put the patient height to measure the ideal body weight for the patient. And there are, like before, we were using the calculation or formula to use or to identify the ideal body weight for the patient. But nowadays, thankfully, with the technology, all the ventilator has the ability to set the idle body weight instead of you. So let's assume that our patient having 170 centimeter height, so his idle body weight is 66 kilogram, and based on that idle body weight, we will identify how much tidal volume we will deliver to the patient. And as Ms. Rajota mentioned before, that the latest guidelines, they mentioned that we need to choose a tidal volume in between 4 to 8 ml per kg based on that idle body weight, not on the actual body weight. Because people, once they get bigger or they get obese, the lung do not change. Maybe the gravity will play an important role, and this is why do we have a prone position. Otherwise, similar people with similar height, they will have the similar lung capacity. So I will start with, if you can see here in this side, we have the respiratory rate. And usually the respiratory rate, I'm talking now about the normal lung. Usually we are varying in between 12 to 20 breaths per minute. And for the tidal volume, the same thing. It's based on our target. The normal target is 6 to 8 ml per kg. If we have very stiff lung or we need to use a lung protective strategy technique, we reduce that tidal volume from 4 to 8 ml per kg, and we compensate for the minute ventilation based on the respiratory rate, either increasing or decreasing the respiratory rate. For normal people, will start with 5 centimeter of water, which is the positive and expiratory pressure, and the end is the oxygen. And usually we start with 100% with oxygen. Depends on the case. So now we'll start the ventilation. This is what you will see in the most of the ventilator. I mean the waveform in the middle. Regardless the view with which was first and which is second, but you will see a pressure waveform and the flow waveform and volume waveform. And if you connect entire CO2, and the machine has the ability to show you how much carbon dioxide patient is having, it will be shown here in the same screen. And if you remember in the presentation, I showed you how do we identify the differences between pressure control and volume control. And in this case, our patient having a volume controls, since there is an ascending form of pressure delivery. And the same thing, we can identify the pressure control by the waveform of the flow. So usually the volume control having a square waveform for the flow, and we can tell a lot about here. We can know a lot of problems from the flow time waveform. I will show you, inshallah, those problem in the last simulator, which has the most smart feature. So this is in basic how it looks like, and this is the measurement of the patient, how much is his peak pressure and how much is minute volume or minute ventilation that the patient has. And because we are setting 530, the patient is having 530 ml in total, and this is his respiratory rate. Anything we change here, let's say if we change it to, for any kind of reason, the patient is getting high pre-blat or something, we can change it immediately. The patient will have those changes. And we are assuming here the patient is fully, he's on sedative and he's fully sedated in this situation. So if we change it to a pressure control mode, some of the parameter will change. Instead of the volume control or the tidal volume, we will have the pressure that we need to set And if you can see here, to deliver 400, because I'm always the student asking me this question, or any RTA, how do we switch from volume control to pressure? From volume control to pressure control. And one of the ways that I'm using is by seeing the pressure on volume control and how much volume is delivered on that pressure. And based on that, I will put 16 here, because on a PIP of 16, 400 total volume is delivered to my patient lung based on his or on my patient compliance and resistance. And after that, for the trigger that we talked about before on who will start the breath, if the patient is semi-awake or he can take a breath by his own, we can simulate that, and we can choose how sensitive is the trigger from the patient. And the higher you go, the more sensitive the circuit will become. And usually the range for like normal patients from 2 to 5 liters per minute, and we have two kinds of flow, whether it's we have two kinds of trigger, whether it's flow trigger or pressure trigger. And 2 to 5 is the magic number for us to use, whether we are using a flow or pressure trigger. Okay, now I will switch to the third and the most smart simulator, which is made by a company called LungSim. Let me. Okay, so this machine or this simulator, we're using mainly for education purposes, since it has most of the problem that we need to solve in the clinic. For instance, like water in the circuit and leak and that kind of problem that we cannot identify until we see it. And I'm always saying to the people that to know the abnormal, we need to know the normal. So if we have the idea about how the normal looks like, anything differing from that normal local, from that normal waveform, we know this is something we need to keep our eye on. So the same thing, as I told you before, I consider, this is my concept, I consider the ventilator as a cars. And since you know how to drive a car, you will be able to drive any car regardless how much specification that the new car has, or how much extra or how many extra details that car has. And the same thing will start with those kind. And the most beautiful things in this lung simulator, it is straightforward. There are no any trade names or different names from the truth. Like volume control here is volume control, pressure control is pressure control, and pressure support is exactly named after the function that it can do. So since we started there with volume control, let's start here with the pressure control. And the same here, we can choose the patient category. And let me start the just to keep in your mind that the patient now, I will make him as an RDS or COVID-19 patient. Just give me a second to change the settings. Okay, I will start as a normal patient. Then during the demonstration, I will dramatically change his. Now he's taking 900. Just make it down. Okay, so 600, I mean, I know it's somehow high, but it's more reasonable than 900. So let's assume this is a COVID patient, normal patient. Usually the COVID patient will have, based on their kind of COVID, whether it's type L or type H, will have a different plateau pressure. And here in this case, we have a peak of 20, as you can see here from this pressure waveform, that 20 is the maximum is reaching, because of a simple reason that we are putting 15 as a pip above the pressure, and the sum of those two pressure is 20. That's why this patient is getting 20. And let's assume this patient compliance is getting worse, and we need to do something to overcome that thing. So let me now make his lung worse by decreasing the compliance. Take time, just give me seconds. So now, as you can see, we decreased his compliance as he is in RDS or COVID situation, because we are giving him pressure of 20, but he is getting like, let me make it worse. He's getting like 300, or maybe let's make it worse. So the peak pressure will not change because he's in pressure control, and tidal volume is getting now is 214 ml in total. So this might not be enough for him due to he has high demands, or he has a high plateau pressure. So we don't know until now. So to know the exact plateau pressure, we need to either switch him to volume control, or we can see from the waveform. Let me change him to volume control to make it very clear for you. Okay, so now because we're controlling just the volume, the peak pressure is 35, and for me 35 is very, very high. And usually when we check that pressure as 35, the first thing we need to check is the plateau pressure, and for sure it's similar to that. And usually we check the plateau pressure with something we called, or maneuver we call inspiratory hold. And once we do the inspiratory hold, all the breath or all the pressure on the inside the lung will stop, and it will measure what kind of pressure, or how much the pressure in the alveoli. So now his plateau is 33, as you can see here. I don't know if you can see it or not, but the B blat is 33. So we need to do something to solve this kind of problem. And usually, if we couldn't make him be lower than 33 on volume control, usually we switch him to a pressure control, just to make sure that we are saving his lungs, because we don't want to create a barotrauma for him, or lung trauma, or alveolar trauma, or any kind of trauma that might make our patient suffer from a pneumothorax and that kind of complication that we don't want. So one of the best solution is to either to follow our just net protocol, and having a very low tidal volume, like starting from 4 ml per kg, and to compensate for the minute ventilation, we need to increase that manipulation. We need to increase the respiratory rate just to compensate for that. And if he has any oxygenation problem, usually we start with high PEEP based on the ARDSNet protocol, like PEEP of 8 or PEEPs of 8, 9, or 10, based on the PEEP study that we are doing with our patient. And usually, I mean, with those kind of maneuvers, inshallah, our patient will get better. But let's do it now in simulation based, since we are in simulation based session. One thing I want to mention about is the IPRV. IPRV is, as Mr. Jota mentioned, is one of the underrated mode, to be honest. I don't know here, like it's not used commonly, but IPRV is one of the modes that will help a lot in COVID patient situation. And this is usually what it looks like, IPRV. The only difference between IPRV and other mode is the IPRV will have let me change the settings to have the best. Let me see here. Sorry, give me 2 seconds to show you the IPRV. Because I'm using like 3 screen, that's why I'm having a lot of simulator open on my screen. So the settings in IPRV is it's a bit different. Usually, I consider IPRV as 2 level of CPAP, and we have high level of CPAP and low level of CPAP, and there are different time in those two levels. And the recommendation usually starting with T high of 5 seconds, and based on your like 4 to 5 seconds based on your patient situation, and T low usually either started from 0.5 seconds, and the P high either you mimic the PEEP pressure that you have, or start with 20 and see your where your patient is going to. And below you have the chance to start with 0. It's up to you. 0 is the recommended starting below, and oxygenation you can for sure. We will never switch to IPRV unless our patient has a problem with the oxygenation. And the beauty of the IPRV is the patient will have the ability to breathe during the ventilation process. So, for example, in this paragraph, you can see here the differences between what I showed you and the regular ventilator settings, and here in IPRV, most of the time and most of the oxygenation is happening here in this area. So that's why we have we are calling that inverse IA ratio. I don't want to go deep with those settings and parameters, but IPRV is one of the most beautiful modes that proved itself in COVID era, or even in ARDS in general since the starting of this mode. The last thing that I want to show you here in this simulation session is how the problem looks like and how to identify it in the ventilator. So I will show you one of the most common a problem in the ventilator settings, which is happening during the COVID-19 era, is the mucus plug. And also one of the things is the, just give me a second, I don't know why this one is.
Gautam?
Yeah, I'm just doing one maneuver. I'm waiting the program to respond to me. Am I on time or? Okay, so I don't know why this is lagging, but just give me 5 seconds. Sorry for that technical issue. Okay. Okay, I will mimic one problem in this waveform, which is the increased or mucus plug or that kind of things. So because he has a bad compliance now, let me switch him to a normal compliance. So if you can see here, the tidal volume is 212, and once we make his compliance better, the tidal volume will change. And now from 212, it will switch to, it will switch to, still I didn't send. Okay, I think I have a lag here. That's why I cannot do anything on the screen. So let me finish this session by talking a little bit about the alarm and just briefly about the alarms and how to set it. And usually with the alarms, each ventilator has its own way of setting the alarm, but most of the ventilator will have something similar. And usually the most important things of those alarms is the pressure and the frequency and tidal volume and the apnea time. And usually the pressure alarm, I was just put it as a roughly number. Usually we are putting that like 10 centimeters above the PIP that we have. And the minute ventilation, most of the textbook, they mention 5% below and above the minute volume that you have. The frequency, 10 breath above and below the one that you set, or the patient that is breathing. Tidal volume, the same thing, they mentioned 10% above and 10% below. Or for me, I'm using like 100 or 75 ml above and 75 ml below. The apnea time, if he is an adult, usually 20 seconds is the most appropriate alarm for the apnea time. And with that apnea time, which will really alarm you about what is the condition of the patient, you need, we don't have to ignore any alarm. It's so important things that so important function that our ventilator have. Sorry for taking very long time, and I'm really sorry for any technical issues that I couldn't show. Thank you for your hosting me. If you have any question, feel free to ask me.
Thank you very much, sir. Sir, we have queries which are posted by our participants in Q&A box and also in chat box. Please, you can answer in that chat box. Sir. So
yes. Okay. Shall I answer it now or later on?
You can answer later on also, sir. Not an issue.
Okay.
The entire session will be available in our university website for further views, and it will be hosted in official Rajiv Gandhi University of Health Sciences YouTube, Facebook, and Twitter also. So with this, we have completed all the 11 sessions in this 2 days workshop. I thank all the speakers for giving wonderful presentations. And now over to you, Mahendra, sir.
Mahendra?
I'm here. Dr. Dayanand, please.
Yeah, I'm there.
Yeah.
I'm there, Mahendra. Okay.
Yeah, please continue. Please invite Dr. Shanai for concluding remarks.
Sir, may I request our respected registrar, sir, Dr. N. Ramakrishna Reddy, sir, to give his closing remarks.
Good evening to all.
Good evening, sir.
The COVID-19 pandemic has been affecting the country for the last 1.5 years, and the second wave has been more severe and threatening. The state is witnessing shortage of valuable healthcare resources. In order to prevent the surge of COVID-19 cases from causing any untoward incidents, it is hereby instructed to make judicious use of the resources, especially oxygen, which is one of the most valuable resources that is used in the management of COVID-19. The government and the university have emphasized the facts to hospitals as well as medical colleges about the rational use of the oxygen, formation of oxygen audit committees, efficient maintenance of liquid oxygen plant, and manifold rooms, and also regular monitoring of oxygen supply and logistics. As the COVID statistics, around 3 to 5 patients have required ICU care. Even today, when the COVID cases are flattening, there is still occupancy of more than 85% of ICU beds in Bangalore, whereas the oxygenated beds occupancy has dropped up to 50%. As the CFR is very high among the ICU patients, the necessity to understand the need and the rationale for the proper airway management at all levels is very crucial. Appropriate and effective use of equipments for the benefit of patients is also essential for the proper and efficient oxygen usage. The proper knowledge about when and how to use the HFNC, NIV, aerosol medication, positioning of the patient, mechanical ventilation, rehabilitation, pediatric care are very important topics, and the speakers have provided the adequate information and elaborate information on these, and I'm sure this will lead a better management of COVID patients and also critical patients. I thank all the presenters and our Honorable Vice Chancellor and the Indian Academy of Respiratory Care and the Professor Shanai, our syndicate member, and the ECHO India for this organizing this essential training program on the fundamentals of respiratory care. Thank you, one and all. Thank you, madam.
Thank you very much, sir. Thank you very much for your closing remarks. Now I request Professor Rajesh Shanai, sir, to propose a vote of thanks. Over to you, Shanai, sir.
Thank you, Dr. Rupashri. These 2 days have been a very good learning experience, especially for the students and faculty. I thank RGHS and IARC for coming together to present this wonderful opportunity for youngsters to learn. I thank Honorable Vice Chancellor, Dr. Sachidanand, Registrar, Dr. Ramakrishna Reddy, Deputy Registrar, Dr. Mahendra, Dr. Dayanand, Dr. Rupashri from RGHS for cooperating and making this a very successful event. I also thank all the panelists who have put in a lot of efforts to provide useful information for our panelists are Jitin K. Sridharan, Mr. Sanjay Sasikumar, Ms. Mridula Swatkar, Ms. Madhura Gauri Shevade, Ms. Dr. Parimala Prasanna Simha, Dr. Manjush Kartika, Ms. Rujita Bagade, Ms. Tisha Ann Skaria, Ms. Momita Chakrabarti, Ms. Anmol Thorbole, Mr. Musalam Al Nasir. I also thank the technical coordination team, Mr. Kirti from RGHS and Mr. Gautam from ECO, without whom it would have been a very difficult task for conducting this online event. And we had around 1,500 registration. Even till the last moment, we had nearly 500 delegates hooked on to this. It shows that it was very informative and it was very helpful. I also thank all the faculty and principals of the colleges who have helped us in disseminating the information on this workshop. I thank the participants, basically faculty and students of RGHS and other universities also. And we would appreciate your feedback through an email. The email addresses have been already given to you. So an email feedback would be appreciated. And we would also like to know if you would like to have such kind of workshops which may be of helpful to you, please suggest us the topics so that we can take it forward. Thank you.
Gautam, you can close the meeting. Dayanand. Dayanand?
Yes, Vijay.
Sorry, it was taken over by Rupas. Sorry.
Hey, no, it's okay. It's okay. It's okay. I told her. Right. No problem. No issue. Okay.
Then, Gautam, you can close the meeting.
Yeah.